Namaste and greetings from Nepal. It is a great honor for me to be a part of the band Ophthalmologica. I would like to thank Dr. Vaibhav Sethi for roping me in for this program. It truly is an honor. Well, I've been asked to introduce a little bit about my music. Personally, I started playing the guitar when I was 10 years old. And there was always conflicting ideas in my head whether to become a full-time musician or whether to have another career. But at this point, I'm very happy I'm able to do both. I have a band called the Blue Fret. The Blue Fret plays original music. Our music mainly focuses on folk as well as the Western genre. We have 7 members in our band. And the special feature about our band is that we have incorporated our ethnic instruments. For example, the sarangi and the flute. So when you hear the band, you get a touch of both Western as well as the Nepali folk music. Our band plays in different venues in Kathmandu. And apart from just playing music, we also have established a not-for-profit called Music for Medicine, where we set aside money for this organization. Music for Medicine, what it does, it sponsors music studies for those students who are unable to afford to pay their fees. We also support salaries of music teachers at institutions that are struggling to make the music happen. And also, we set aside money for the free treatment of patients. So this has been going on for quite a while now. I remember the first time that we started raising money for treatment was back when I was a postgraduate student in Manipal. That was, I forgot, many years ago. But with Dr. Biju Raju, Rohan Daniel, and we formed a band called the Donesis, like the Faco Donesis, and we were able to raise money and start a fund called the SRF, which is the Site Restoration Fund. So that has continued even now in my career. So I'm very glad that this concept came together by the 3 of us then, ophthalmic residents, trying to do something with our music. Apart from the music, we have also a not-for-profit organization called Ek Ek Paila. It was founded during the time of the earthquake, when Nepal was severely affected by the earthquake, in fact devastated by the earthquake. And a group of medical doctors and like-minded friends, we went to these earthquake devastated areas to provide medical services. And it was all on voluntary basis. After a period of 1 year, we realized that we had become great friends, and we thought, why not register these organizations and do the medical services more seriously? Which led me to follow another path in my life, where I resigned as the head of the Department of Glaucoma, head of the Department of Research at Tilganga Institute, and started my journey as a volunteer at Ek Ek Paila. And today, we are proud that we have traveled extensively in remote areas of Nepal, where we provide comprehensive health service, not just ophthalmology, but the entire outfit of setting up a small clinic in the remote areas and providing ENT surgery, eye surgery, gynae, and minor operations, sometimes even major operations, working with the primary health centers, dental surgery, and also providing the people there with music. So often the band joins our areas, joins our mission to provide music to the community there. And most of the funds are raised through the Nepalese in Nepal and overseas. So we have very much a Nepalese run organization, trying our best not to depend on foreign aid, but we welcome our friends donating from all over the world, but 90% of the funds are generated through the Nepalese diaspora in overseas, as well as the local residents here. Well, this is what it is, and I think now you should just hear the music that Vaibhav insisted that I come and join over here. And music is something that is so abstract. Some people will like it, some people won't. But I do hope you will enjoy the music, and hope you will be able to come to Nepal sometime and attend our shows. And if not for the music, come to Nepal and I can be your travel guide, and I can tell you something and show you around my country. And yes, so that's it, and it's a great honor, and thank you so much, and I hope you guys have a wonderful webinar.
Don't say hello. You've been away too long. Don't say you need me. I've been holding on too long. Don't you try to make it right. Don't say you want me. It's hard not to fight. But don't you dare say the words that I want to hear. You can see right through me, but I couldn't care. And at times like these, I try not to say I need you. At times like these, I try not to say I want you. Don't say hello. You've been away too long. Don't say you need me. I've been holding on too long. But don't you try to make it right. Don't say you want me. It's hard not to cry. And at times like these, I try not to say I need you. At times like these, oh, at times like these, I try not to say I love you. Don't say hello. I may have everything, yet I feel there is nothing. A way my life can be, I feel the rain pouring down on me. My troubled mind and soul, it doesn't let me get a hold. A day without you now, it seems like the sun's going down. I try and try to pretend it's alright. The nights are long when the stars don't shine. A new morn was a day behind. I can't understand the way it's out of hand. Maybe you are the reason why. We could try when the nights are long and the stars don't shine. A new morn will show us the light. We can then understand the way it was out of hand. There wouldn't be a reason why. There wouldn't be a reason why. There wouldn't be a reason. There wouldn't be a reason. There wouldn't be a reason why. I got so much going on. I feel alright, I'm walking tall. If you love me, then come right here. Stay with me and make it clear. If you want me tonight, you've got everything going right. I'm in a mood for some moonshine with you every night. So come on, sugar. Can you feel it? Do you feel it coming, honey, baby? I wanna know if it makes me blue. I'm gonna go. I got so much going on. I feel alright, I'm walking tall. If you love me, then come right here. Stay with me and make it clear, honey. Do you feel it? Can you feel it coming, honey, baby? Is it true? I wanna know. If it makes me blue, I'm gonna go. I got so much going on. Can you feel it coming? Ooh, I got so much going on. And oh, Melissa, I can't complain. You are my sunshine in the rain, and I can play a tune on a sleepy afternoon to you. Oh, Melissa, Melissa. Oh, it's true. At times I'm lonely, well that's nothing new. My heart feels weary dreaming of you. At times I'm flying and I could touch the moon. Your love comes pouring to wash away my wounds and hard and trying times and all the sleepless nights in a world so unkind when friends can't be found. You take away the blues. Oh, Melissa, Melissa. Whoa, whoa, ooh, it's true. And ooh, Melissa. Oh, it's true. मेरो आवाज सुनिदेऊ, मनको कुरा बुझिदेऊ, मेरो साथ हिँडिदेऊ, कहिले नछोड मेरो हात। एक एक पाइला हिँड्दा पनि मलाई पछि नछाड, पर्खेर तिमीलाई सम्झे यही बेला एक्लोपनमा निराश लाग्दा बिर्सेको दिन कहिले पनि सधैँ रह्यौ मुटुभरि भन्न सकिन मनको कुरा तिमी नै हौ मेरो संसार आउँदैछु म तिमी कहाँ सधैँलाई आकाशमा तिमी हौ मेरो प्रकाश एक्लो यो जीवनमा तिमी नै हौ मेरो सहारा मेरो आवाज सुनिदेऊ मनको कुरा बुझिदेऊ मेरो सहारा हिँडिदेऊ कहिले नछोड मेरो हात एक एक पाइला
Namaste. Good morning, good afternoon, and good evening. Welcome to the world of Pan Ophthalmologica. Pan Ophthalmologica is not just a webinar, it's a collaboration. It's a collaboration between 20 countries, from Australia to Argentina, from Brazil to Bolivia, from Germany to Greece, where over 100 ophthalmologists all across the globe have come together to share knowledge, share their experience and their challenges with one aim: to learn from each other. Today is the World Sight Day, and we celebrate the gift of vision or the gift of sight. Sight is a beautiful symphony of color, light, and beauty, and it's just like music as it transcends boundaries, languages, and culture. We just heard Dr. Suman Thapa and the Blue Thread Band playing beautifully, and how there's a beautiful harmony and synchrony between music and science. Today, we have over 9 virtual halls with over 20 captivating sessions of ophthalmology, and over the next 2 to 3 hours, I hope you all will enjoy as much as we did to put together this program, and I hope that we see everybody soon, and let us start this symphony of knowledge and creativity. Thank you for your attention. Looking forward to seeing you. Namaste.
Next session, please.
Good evening, everybody. Now we switch on to our halls. Good evening, Ketki. Can you hear me?
Yes, I can hear you. Hi.
How are you?
Good. Let's go ahead and start the session now.
We have about 3-4 minutes. I'll let everybody join in.
Okay.
And I think Advait is already here. We have Dr. Hudson here. Hi, sir. How are you? So he's logging in from Brazil.
Cool, here. There's music. There's passion.
See you. Your internet is a little choppy.
So, good evening, everyone.
Hi, Bharat. How are you? You missed the music?
Fine, sir. Very excited to be here. This looks to be a very interesting session, and we have so many prolific speakers here. So, we'll be able to start in a minute.
Yeah, I think so.
Hello, Dr. Bharat.
Hello, Dr. Ketki. We have been communicating on WhatsApp for a while, but it's been very hectic because I work 1.5 hours away from my place.
Oh,
So I've been traveling.
exciting day.
So when shall we start?
Hi, Dr. Aditya. Hi,
Hi.
Dr. Ketki.
Hi,
Dr. Bharat, sir.
Nishant.
Hi.
Dr. Nishant here from Chennai.
So, Dr. Hudson, we have cornea specialists from Chennai, Dr. Nishant. We have one refractive surgeon cornea specialist from Hyderabad who's going to be talking next, Dr. Advait. And Dr. Hudson is a VR surgeon from Brazil.
I'm just turning my mic on. It was off for a while, but I'm just coming in by now. And you asked if I have his contact or his faculty.
So, Dr. Hudson, if you are ready, then we can begin with your talk. If you have a shortage of time, then let's begin with your talk.
Hudson's on the panel.
That's okay.
He's on the panelist.
Oh, yeah, let me just correct.
We have Dr. Advait as well. Hi, Dr. Advait.
Hi.
Hello, sir. Hello, Dr. Nishant. How are you?
Good.
Dr. Samresh is also here.
I'm having
Hi, good evening.
a little issue
Welcome.
with my microphone. Just let me just turn it on. My talk is ready. Just a second here. Let me just.
So, Dr. Advait, are you ready with your talk?
But yeah, just 2 minutes. We start. All right. Advait, you want to try out?
I guess my sound is better now. Aditya, can you hear me?
We can hear you loud and clear.
All right.
Great. So we've got a batch of young ophthalmologists who are going to show you some surgical techniques that they follow, and we want your comments. We have Dr. Shikha ma'am also with us. Hi, ma'am. How are you?
Hello, ma'am.
Madam, you're muted.
And we have Dr. Samresh here.
Sorry.
And he is
I-
Hi, ma'am. So I think we can start.
We can start.
Over to you.
Formal start.
Yes.
A very good evening to all. I, Dr. Ketaki Subedar, and I will be moderating the session with Dr. Bharat Mehta. And I want to welcome you all to the YOC session of Pan Ophthalmologica and thank on behalf of Deseret Eye Hospital. We are going to today start the YOC session with a good mix of retina, refractive surgeries, and cataract. And on the panel, we have Dr. Hudson Nakamura, vitreoretinal surgeon from Brazil, and he's the titular partner member of Brazilian Vitreoretinal Society. He's the man behind the Retinawesome. We also have Dr. Shikha Basi, ma'am, Deputy Director of Neuro-Ophthalmology Services at Shankar Nethralaya, Chennai. We also have Dr. Samresh Srivastav, cataract and refractive consultant at Raghudeep Eye Hospital and prolific cataract retina refractive surgeon. So I welcome you all, and I think, we'll start with Dr. Advait, right? I welcome Dr. Advait to give his first talk. He's from Hyderabad, and he's the founder of Envision LASIK Center. And I think you can start sharing your screen.
Yeah, sure. Thank you, Dr. Ketty. Just let me know if it is.
Yeah. He's the medical director at Sai Jyoti Eye Hospital, Hyderabad, and fantastic cornea and refractive surgeon. He's starting soon.
Is it visible? My screen?
Yes,
okay?
it is. Yes.
All right. Okay. Thank you, Dr. Aditya, and thank you, Dr. Ketki, for this wonderful opportunity, and happy World Sight Day to everyone. So I've been given the topic ICL for beginners, so I have simplified my topic as much as I could. So basically, we'll be talking about the phakic lenses today. That is the implantable collamer lenses. So ICL is basically the lens which is implanted in the eye, and it is positioned behind the iris and right in front of the natural lens, which is basically used to correct the myopia, hyperopia, or astigmatism. Now, there are different types of phakic lenses that are commercially available. We have the ICL, which is most commonly used, that is from the phakic from the RIL from the Apasamy, and the IBCL from the Care Group. Now, ICL is basically made of collamer, which is basically collagen and copolymer. It is biocompatible, which basically gives you a quiet eye post-operatively. It is US FDA approved. It has a high water content, which is safe to the ops. It has a refractive index, which is close to the aqueous, which basically minimizes the internal reflection and also minimizes the high rod aberrations. Now, what exactly is collamer? Now, collamer is basically derived from two words that describe the composition of the material, which basically are the collagen and the copolymer. Now, collamer is a copolymer biocompatible material. Like I said, it gives you a post-operatively white eye. Now, for the ICL, the workup is just like any other refractive surgery. We need to get a detailed systemic history and ocular history. Ask whether a patient is using any contact lenses, and to discontinue the contact lenses at least 2 weeks prior to any examination. Thorough manifest and cycloplegic refraction needs to be done. Thorough anterior segment evaluation, where emphasis should be made on the anterior chamber and the angles. Look for any inflammation and also the size of the pupil. Thorough, detailed peripheral fundus examination needs to be done. And in case of any peripheral lesions, Barras laser needs to be done at least 2 to 3 weeks before doing the ICL procedure. The measurements are the most important part. Now, the first and foremost is the anterior chamber depth, which has to be measured from the endothelium. Now, some topography gives the measurements from the epithelium, so we need to make sure the AC depth is measured from the endothelium. The central corneal thickness, the horizontal white to white, which I'll be coming to about in the next slides, the K values, the axial length, the endothelial cell density, and the intraocular pressure. Now, the eligibility criteria is like any other refractive surgeries. The patient needs to be more than 21 years old. The refraction needs to be stable for at least 1 year. The AC depth needs to be more than 2.8 millimeters for myopia and more than 3 millimeters for hyperopia. The angle should be wide, which should be at least grade 3 on gonioscopy, and the endothelial cell count should be normal, and the intraocular pressure should be normal. Indications are high myopia, thin corneas, patients who are unfit for any refractive procedures like PRK, LASIK, or SMILE, any ectasia like keratoconus, dry eye diseases, basically because any refractive surgery can induce some dryness, unlike ICL procedure. And if the residual stromal thickness is falling less than 400, such patients are ideal candidates for ICL surgery. The contraindications are any endothelial dystrophies, if the patient is having any glaucoma or ocular hypertension, cataract, narrow angles, if the patient is pregnant or breastfeeding, one-eyed, if there's any inflammatory conditions. So the horizontal white to white is the most important, like I said. So horizontal white to white is measured by various ways. One of the most important and the more accurate one is the distal caliper. Distal caliper, it can be measured under the microscope or using a slit lamp examination. Of course, the white to white can also be measured through your topography unit or your IOL master. Normally, what I do is I measure the white to white from my IOL master 700. I compare it with the topography, and then I do the digital caliper, and I cross-reference with all the three parameters, and then I send to the company, and that's when they give the lenses to me. Because ideal vault size is very important. What exactly is a vault? Now, vault is basically the distance between the posterior surface of the ICL and the anterior surface of the crystalline lens. So vault is something that you need to look for post-operatively. The vault size should be between 250 microns to 750 microns, which is about half corneal thickness to about 1.5 corneal thickness. So surgery is normally performed under topical anesthesia. Initially, always to load the lens the patients into the operation theater, because loading itself can take about 5 to 10 minutes. And once you drape the eye, the first step is you take a side port and inject some viscoelastic. Do not overfill the eye with visco. And then you inject your ICL into the AC. And once you inject it, you just have to tuck in the haptics into the sulcus. And then you can do a thorough visco wash. You can use a bimanual irrigation aspiration to a visco wash. You can inject some pilocarpine just to constrict the pupil, and then you can hydrate the wound. So this is how the lens design is of the ICL. Now ICL has three, as you can see, there are three holes in the center on the body, which is about 360 microns. This allows the aqueous drainage, the aqueous flow, and this eliminates the need for any peripheral hydrotomies. We also have two holes in the foot plates. Now this will give you a correct orientation of the ICL if it is opening in the right direction or not. And in case of toric lenses, we have two lines over here. This will determine about the toric alignment marking. So this is how a toric ICL looks like. It's just like an intraocular lens, but it gives a line which would basically which comes with the toric chart, where the patient's the power, the position of the lens is mentioned over here. So we have to do your toric marking just like how we do our intraocular lenses, and then rotate the ICL just like how you rotate your intraocular lenses. The advantage is the lens is very soft and you don't have to rotate too much. Normally it's less than 15 to 20 degrees of rotation for any ICL. So the aqueous flow through the central port, basically the advantage of this is it eliminates the need for any peripheral hydrotomies. It also, one more advantage is you can easily wash off the visco which is tapped between the ICL and the natural lens, and it gives an excellent quality of vision. And of course, the most important part is the stability of the intraocular pressure. So post-operatively, the medications will be like any other cataract surgery. You start your patient with your steroids and antibiotics. Post-operatively, you need to check the vision, the intraocular pressures, the AR findings, the sizing of the vault, and your slit lamp findings. Like I said, the normal vault size is about half to 1.5 corneal thickness. Check the patients after a couple of hours, and then check the patient post-operative day 1. When the eye is quiet and patient is comfortable, then you can plan your other eye. So how do we start off? For beginners, how do we start off? Now, the advantage of ICL is you don't need an expensive setup like your refractive setup. You don't need to spend crores and crores of rupees. You just require a normal, regular cataract OD setup. The ICL or any other phakic lens team will be there to assist you till you become confident. They will come and they'll teach you about your loading of the lenses and how to deal with any complications till you become confident. And the lens is extremely soft. It is very easy on the natural lens. Even if it does touch the lens, it does not disturb the lens capsule. Rare cases, in case the lens flips, which most of us are worried about, it is very soft. It can be easily explanted and reimplanted in the same setting. And of course, an advantage of ICL is it's always reversible. So tips is, so basically, initially, when we are starting off doing ICL, it is important that you load the ICL before shifting patient to the OR because loading it's taking about 5 to 10 minutes. Once you're comfortable after loading the lens, then you can shift the patient and you can do your draping and then you can start off your case. Remember, there is very less space to maneuver in phakic lenses, so be very gentle and be very slow. A good visco wash is very important. I prefer bimanual irrigation aspiration. Do a visco wash for at least 1 minute. Make sure you do a thorough visco wash. Don't leave any visco because that could lead to any intraocular pressure spike post-operatively. Check immediately post-operatively. Look for the vision, AR, eyes quiet. Check for the NCT, check for the intraocular pressure, and then you can discharge the patient. Once the patient is comfortable, then you can plan your second eye. Thank you. Thank you so much.
Thank you, Dr. Advait, for this detailed overview about the ICL. I would invite Dr. Samresh sir for any tips that he has for ICL.
Yeah. Am I audible?
Yes, sir.
Yeah.
All right. Dr. Advait, that was a great comprehensive presentation, actually. It was like a revision for me also. So it was nice. I wanted to add a couple of comments because so one thing is that I don't really offer ICLs only to patients who are now unsuitable for any refractive surgery. More and more, actually, patients above 8 diopters of myopia, I am actually primarily counseling them for ICLs over a corneal-based surgery because the quality of nighttime vision, no matter what we do, any level of topo-guided treatment or optimized treatment, there is a slight bit of halos-in glare that will come after your K readings go down by a certain amount because your cornea does become flat. So my primary preference for high myopes is ICL. And if ICL is a price factor and then their PACI is extremely good, then I offer them refractive cornea-based surgery. Okay, so that's just a slight difference. The second thing is I wanted to ask you, what viscoelastic are you using for implantation?
Sir, I'm using HPMC, sir.
HPMC, yeah. So what I've learned over the years, with practices, that sometimes this HPMC is not really a viscoelastic, because it has no viscoelastic properties and some of it can stay behind and may cause an IOP spike. So I've shifted to more cohesive viscoelastic, maybe like a Helon or a Provisc or any of the Indian companies, because it comes out en masse. So your chances of having a post-operative IOP spike or inflammation becomes really low. And it can even come out easily through the small ports like you had mentioned. So, shifting off to, at some point in time, try out cohesives because it will be really nice, like hyaluronate. Again, one more small tip is I've burned my fingers with almost fully dilated eyes that have been shifted into OR. So I think it's wise to take all the time possible because you don't want small pupil or, like a 6-7 mm pupil. You want a full dilatation in these eyes because tucking becomes really easy. And last, for junior surgeons, because it's a YOSI session, it's a large incision. So if you're not confident, I wouldn't hesitate in taking 1 or 2 sutures in the beginning before confidence builds up to leave these incisions by hydrating alone. That apart, I think you covered everything really
well. Thank you so much for your valuable input, sir. And it would be my pleasure to welcome Dr. Zain Khatib as our next speaker. He is a consultant ophthalmologist at Khatib Eye Clinic and Perfect Vision Laser Center, Mumbai. He's an expert in cataract surgery, LASIK, refractive surgery, and glaucoma. He is an MBBS from the prestigious State GS Medical College and KEM Hospital, Mumbai, with an MS from Karnataka Institute of Medical Sciences, Hubli. He has a DNB in Opthal with an FICO, MRCS, FAICO in cataract, an FAICO in refractive surgery, and an FCP. He has been fellowship trained in phaco-refractive and advanced anterior segment surgery from Lakshmi Eye Institute, Mumbai, and Moran Eye Center, Salt Lake City, USA. He is a recipient of multiple international awards and a recipient of multiple local as well as All India Ophthalmological Awards. Please welcome Dr. Zain. Dr. Zain, are you there?
Yeah, thank you, sir. Thank you for the kind words and introduction. So I'll just share my screen.
Yes, please do.
Is my screen visible?
Yes, please go ahead.
Okay. At the outset, I'd like to thank Dr. Aditya and PAN Ophthalmologica for giving me this opportunity. And on World Sight Day today. It's a great webinar to have. So basically, I'm going to be showcasing a video which is titled "The Blue Volcano." So this was just to give you a backdrop. Was the last case of my OT list, and it was a toric IOL. If you can see, the toric marks are already done, and it was a routine case, kind of nuclear sclerosis grade 2 with anterior capsular cataract, and I was getting ready to just finish off and go start my OPD. Okay. So I start off by making the incision, how I do routinely, and just see what happens after I make the incision. Okay, I make the incision, and from nowhere, I'm seeing things coming out of the wound. At this stage, you try to convince yourself that there's nothing wrong. I injected blue dye, and after injecting blue dye, what I call the blue volcano, I could see, blue color jelly coming out of the eye profusely. And, I was getting ready to pack up and go see my OPD, but, I wasn't sure. After, some thinking, I decided to fill the chamber with dispersive OVD. And now you can see after injecting dispersive OVD that there's a large area of subluxation. Okay, so this large area of subluxation was missed preoperatively, or it wasn't seen. And what also is not seen is that the whole lens is kind of tilted down, which you can't appreciate here, but that was the case. Anyways, I did not want to panic. I thought I'll just, follow some basic principles and go ahead and try to do what I can to the best of my ability. So to make the rhexis, the first thing was that, it wasn't happening with the forceps. So I use a straight cystitome to make an incision, because whenever there's lack of zonular support to make the entry, it's always better to use a straight cystitome. And then, carefully I make a rhexis. The rhexis turns out to be a little smaller. And then I go ahead and do a hydrodissection. Now, before I go ahead with nucleus rotation, after doing the hydrodissection, it's always important to get the counter traction of the bag before you try to rotate. So in order to get the counter traction, we have to provide the counter traction with additional support in the area of subluxation. So I insert 2 iris hooks just to give me that counter traction to rotate. And after inserting the iris hooks, I try to rotate the nucleus bimanually. But it doesn't happen because the counter traction is not enough. We need equatorial support as well. And that's when I decided to put a CTR. So a CTR along with iris hooks actually gives very good counter traction. And now you can see after doing this, I'm able to, rotate the nucleus. And once the nucleus is rotated, I'm going ahead with phaco. Now phaco, very important that you do the technique which has least amount of fluidics. And that is the divide and conquer, or the 4-quadrant technique. So I'm going ahead and doing phaco with 4-quadrant. And it's not a very hard cataract, but at the same, still I'm just breaking it into 4 segments by trenching rather than using too much of vacuum. And as soon as the phaco is over and I get the things out, you can see how the whole thing has come forward, and then the next step is to do a thorough anterior vitrectomy in this case. Once the vitrectomy is completed, I'm going ahead and doing the cortex removal. But just note, there's a lot of positive vitreous pressure in this case. So when I go to inject the IOL, actually I realize that I'm not able to inject it because the moment I'm depressing the wound, from the same place vitreous is coming out. So I thought I'll do a little more vitrectomy before I inject the IOL. So I gently pull back the strands of vitreous and then I'm doing a vitrectomy, and I'm planning to put the same lens that was planned, that is the toric lens, which is in the bag. And I dial the IOL into the bag. You can see that, there's still a lot of vitreous pressure. And now once the lens is in the bag, I remove the iris hook and just have a look at the eye. The lens doesn't look centered at all. And the reason for this is because that vitreous pressure is so high, it is pushing the bag to the side and coming out through that wound which is there. So we cannot complete the case at this stage. We have 2 options. The first option is to give support by fixing that bag to the sclera. But I feel that is not necessary in this case. We just need to reduce the vitreous volume in that area. And that is what I decide to do. Instead of doing a scleral fixation, I decide to go ahead and do a pars plana vitrectomy to reduce the vitreous pressure. And once this pars plana vitrectomy is completed, you can see, this bag is now falling well into place. The IOL is getting centered. And now I'm able to dial this IOL, the toric IOL, to the desired axis. And we can see the IOL is now nicely centered on the axis. And, with that, I remove the pars plana port and I hydrate the wounds. And this patient ended up having a good outcome. So I just wanted to demonstrate this case. Thank you.
Wonderfully handled, Dr. Zain, and it's definitely a lesson for us. Any problems with redialing of the IOL? Did it shift after surgery once the pressure built up?
No, the IOL was very stable and it was well aligned even in the post-operative period. So the patient was actually 6x6 for distance.
We have Dr. Hudson here. Dr. Hudson, sir, being a retina specialist, how do you feel he handled as an anterior segment specialist? Do you think he did the right thing by doing the pars plana vitrectomy, or would you have approached differently?
Very interesting when he put the ring and things got more stable because he was not able to rotate nucleus. I think it was pretty okay. And I would go on with only anterior vitrectomy. I think that would be enough. I don't think he would need a pars plana vitrectomy, maybe just for the anterior segment. But the case was very well managed. Congratulations, really beautiful.
Thank you, sir.
Any questions for ma'am? Hi, ma'am. Ma'am, you're muted.
Very well managed case indeed. And as the saying goes, all's well that ends well. But there are a couple of things where, things could have gone really wrong because you started phacoing with the vitreous right there in the wound. You managed the thing when, you did everything to center the IOL, but things could have gone really bad with the vitreous in the wound and you phacoing. I understand that you had used techniques which don't use very high fluidics. But then still, the science says that if the vitreous is there, coming in the way of your phacoemulsification, that has to be cleared. That shouldn't be in the field of surgical field, but you manage the entire thing scientifically. By whichever way, do a limited anterior vitrectomy, clear the anterior segment of the vitreous, and then proceed with whatever you've done. You can indeed put torics once you've stabilized the back, and torics don't behave. There's nothing much to lose in torics. They don't cause as much of a problem with other premium lenses like multifocals, and those lenses have got a problem if they get decentered. But with torics, they're more forgiving. So my only problem was, clearing the field of surgery of vitreous before doing a phacoemulsification. But you've graduated. You see, your surgery was very, very good.
Thank you, ma'am. So just to clarify that, I had done actually a limited anterior vitrectomy before starting the phaco, which I edited out. And then I used a heavy dispersive viscoelastic viscoat to tamponade. So during the phaco, there was no vitreous actually in the chamber. It was cleared. But the vitreous started coming after I removed the phaco probe. That is when the real pressure of the vitreous came forward.
So you didn't land up with any problem, right? You didn't land up with the problem because it was clear. Did you mention that while you were playing? I'm like, when you were showing the video, did I miss that part? Did you say?
No.
That was a very, very important bit.
Yeah.
Okay.
So one more thing, I'd just like to add a small comment, just to finish Madam's talk. I think Dr. Zain, again, like with everybody else, you managed the day very well. But again, for the junior doctors, I think any sort of visualization, one should not hesitate from using triamcinolone because you know the anatomy then very well. So, with experience, even though you can see the vitreous, even now I can sometimes miss it. So I would encourage all of you to use triamcinolone and keep it handy whenever possible.
My only issue with triamcinolone is that it really hampers the red glow for the rest of the surgery. This is what I feel.
Yeah, but it's
find that
really
very cumbersome.
So yeah, I mean, if you have one wig remaining that goes out, there's a potential for infection, which is far higher a risk than the red glow. So.
But Zain, you had used blue ring, no? Didn't that seep in? I mean, like blue ring is worse than the triamcinolone for removing the red glow. Maybe the patient was a little younger.
Yeah, patient was younger. Patient was around 42.
Yeah. So the vitreous was not liquefied. Older patients, if you put a blue ring with this kind of problem, you'll lose the blue. The glow completely. This was a younger patient, and very importantly, this was quite a big subluxation or zonular loss. Shouldn't have been missed preoperatively. A well dilated slit lamp examination can show this up.
True. Very true.
Before we move on to the next talk, thank you, Zen. Dr. Hudson has a quick comment, and then we'll move to the next talk.
Sure. I just want to comment that I myself, I like not using much triamcinolone because I usually get to see the vitreous. I like seeing the vitreous at the posterior chamber. And so after vitrectomy, you're going to see later on the retinoplasty session, my vitrectomy surgeries. I usually don't stain the vitreous because I like the lens and the appropriate zoom to see the vitreous. So this is only one option. I just wanted to comment on that.
All right, thank you, sir. Moving on to the next talk, I would like to introduce my friend and meticulous cataract surgeon, Dr. Nikunj Tang. And you may load your presentation meanwhile. So he's a consultant at SRJ Netralaya in Cornea, Cataract and Refractive Department. And he loves teaching, and he's the co-editor of YouTube channel of Video Assisted Teaching, VAST for YouTube. And he's also the assistant editor of official YouTube channel at EOC. As associate editor at Global Journal of Cataract Surgery and Research in Ophthalmology. His special interests are in challenging cases and complex cases with iris repairs. Now let's see what he has to present. Welcome, Dr. Nikunj.
Thank you, Dr. Ketki, and really nice to meet you after a long time, virtually at least. And thank you, Dr. Aditya, and for inviting me there for this wonderful webinar. Wonderful surgeries. Zain is a good friend of mine and always love to say his surgeries. So I'll be going a little different. Let me just start sharing my screen first. Yeah. So I'll be showing a video of this surgical case. I'm actually showing just part one of the complete case, which is actually the anterior segment management. It was a case of doing phaco in a case of a case where we have removed a large intraocular foreign body 15 days back, and then we were planning about cataract plus vitrectomy surgery, and there were few challenges because of the demand from the vitreoretinal surgeon as well as what was the situation of the patient. So let's start with that. So in generally routine cases, we get a very good glow, just like Zain mentioned that we all love anterior segment surgeons like to have a good glow. In cases like in this case where cortical cataract was very visible with the retroillumination, but in this particular case there was zero retroillumination. So it was very difficult to access the tissue intraoperatively. So this is the initial surgery, just a glimpse of it. Operating surgeon is Dr. Kushagra Jain, who is a vitreoretinal surgeon at SRJ Netralaya. You can see a large big metallic foreign body was removed and the primary scleral tear injury repair was done. He tried to access the vitreous at that time, but he was not able to because there was a lot of blood inside. And it was almost 10 more than 10 millimeter of size. So second surgery was phaco plus planned sulcus implantation and followed by vitrectomy, because during preoperative evaluation, we noticed that there is a lot of blood and the posterior capsule is actually attached to the blood and clots, and there was so much of fibrinous tissue attached to the posterior capsule. So he told me that he might have to remove the posterior capsule, so I cannot put IOL in the bag and I have to do an optic capture. We thought of using this vitreoretina illumination as a chandelier illumination, but there was a lot of blood, so it wouldn't have given us any glow because there is no fundus to get a retroillumination from. So I decided to use trypan blue dye as for some of the help in this case, and stain the anterior capsule in a usual manner, and plan my incisions routinely as I do temporal phaco in most of my cases. And using a system, I started the capsular exit. This was a very young patient, probably in his 20s actually, and the capsule was quite a bit elastic. It was a little difficult to initiate the flap, but gradually I was able to get the flap. The pressure was on my mind was that I have to get a circular, well-centered capsular axis, as I want to plan an optic capture in this particular case, and that is very important for a long-term IOL stability. So I was moving ahead with my capsular axis, and I reached near the main incision. It was starting a bit going outside. So I decided to use the micro forceps and accessing it from the side port incision, which gives a better control as well as better chamber stability. And while using high molecular weight OVD, sodium hyaluronate in this case, multiple times, I was keeping the flap flat and then slowly and gradually making the pivoting of the capsular axis flap, and was able to complete the axis, even though it is really blind. Whatever is visible in the camera, it is even actually not get visible in actual scenario. So after completing the capsular axis, I will switch off my microscope and confirm my capsular axis all around using the light pipe. And it was fairly okay from all around. It was a almost circular capsular axis. And you can see a lot of, you can see visible vitreous hemorrhage just behind the PC. The cataract was soft. It was a recent injury, but with a little bit of posterior subcapsular cataract. The rest of the nucleus and cortical matter was really soft. So I decided to use only irrigation aspiration. I use coaxial irrigation aspiration. That is my go-to technique. And it was removed in a usual fashion. Fortunately, there was no any zonular weakness or any other surprise which can happen in any such traumatic cases. So you can see here, after removing of the cataract, the well-centered circular capsular axis was achieved. And you can see a lot of blood hemorrhage behind the posterior capsule, more visible now, which is going to be removed by vitrectomy. So as planned, I decided to implant a multi-piece, 3-piece IOL in the sulcus with one haptic targeting going in directly into the sulcus, and the second haptic will be dialed gradually. So while dialing into the sulcus, there are two techniques which I follow. I generally do tuck in most of the time, where you just tuck the haptic under the iris and just leave it there. It will go into the sulcus. Otherwise, you can do gentle dialing. And sometimes there's a notch in your iris tissue, which is indicating that your haptic is behind the iris. And the second step was pushing the optics under the capsular axis margin. Here there is zero glow, so it is not visible as it should be because of retroillumination is not there, but optic capture was achieved and main incision was sutured. And now the case is ready for the vitreoretina surgery. And this is how it was inside in the posterior chamber. There was a lot of blood all around where is retina, it was not visible, but my colleague was able to achieve good surgery at the end, and the retina was settled, and patient is yet to recover. We are yet to see his final follow-up at 1 month. This surgery, I think the photograph I've shown is only 1 week post-op. Thank you so much.
Thank you, Dr. Nikunj. A very well managed case and very good outcome at the end of it. I would like to ask panelists to give their input.
Yeah. So I think I'll start. Dr. Nikunj, Dr. Hudson, after you. Please go ahead.
You're on
mute.
Okay. I just wanted to comment that after the anterior capsule was unstable and it ran out, and then by that time you did the right decision to try to make it stable and curve around it, and then you put the IOL just over on the top of the capsular rhexis and the anterior capsule. That was very well managed, and you commented on some adherences from the iris, from the bottom of the iris. So a different technique that you would use if you insert the IOL and you get some resistance on the bottom of the iris, how could you see it, and what would you do at this time?
Sorry, sir. I think I was not trying to say that there was resistance in this case. I was trying to show that when you're putting the IOL in the sulcus, how to make sure that your haptics are in the sulcus, because sometimes there is a dragging of iris tissue along the haptic. So that is actually indicative that your haptics are into sulcus. But to your question, if you are getting this kind of resistance, then there can be a posterior synechia which are developed because of the inflammation. And in those cases, I would generally like to do a viscodissection or use iris spatula to get some kind of separation in that area, followed by getting the access to the sulcus in that area. Any other comment from? Yeah.
Thanks.
So Dr. Nikunj, first thing, I think it was a very smart use of endo illuminator, or using us on the sides to see, because sometimes when nothing works, assisted illumination techniques. If you have it in your OT, why not use it? So I think it's a very smart thing to do. We normally use it for corneal opacities here and there to try and find a window to see.
Right.
As I see, your primary choice for the IOL implantation was a 3-piece from the beginning.
Yes.
And why did you not choose to put a lens in the bag?
Because, sir, the posterior capsule is completely compromised in this case. Iatrogenically, my vitreoretina surgeon was going to remove the vitreous hemorrhage, which was densely adherent to the posterior capsule, and along with that, he was going to eat away the posterior capsule. That was his demand, that he will compromise the posterior capsule. So I have to choose a lens according to what would be the better stability on a long-term basis. If he would have done just a central posterior capsular axis, then I would have chosen a in the bag implantation. But the vitreous hemorrhage was more on the side as well. If you saw in the video, then quite a bit of posterior capsule was actually compromised during the VR surgery. And that's why I decided to put the 3-piece IOL in the sulcus with the optic capture. Yeah.
So very, very well managed.
Thank you, sir.
So thank you, Dr. Nikunj, and it would be my pleasure to introduce my next speaker, Dr. Kartikeya Singh. He's done his MS Ophthalmology from the prestigious BJ Medical College, Ahmedabad, followed by a FACO Fellowship under Carl Zeiss from Gujarat, and a Vitreoretina Fellowship from the prestigious Joshi Institute. He is currently working as a phaco-refractive and vitreoretina surgeon in AST Varanasi, and he has been active in a lot of international and national conferences as an organizer and as a speaker. May I introduce Dr. Kartikeya?
So I'll be playing Kartikeya's video, then he'll take questions from the panel. So there we are. And
good evening, everyone. Myself, Dr. Kartikeya. I'll be taking you through a mysterious case of bilateral nucleus drop with unilateral chronic RD. Thank you, Dr. Aditya and Team Joshi, for giving me this opportunity. So without wasting much time, I'll take you to the case. There was a 32-year-old male who had DOB in right eye since 2 years and in left eye since 1 month. No history of trauma, systemic illness, or anything else. Rheumatology workup, even the consultation with rheumatologist, everything came out to be normal. Vision in right eye was PL positive with IOP of 5, and in left eye it was 6/18 with IOP of 15. Was using +4 diopter glasses in the past, but record of which now he was not using recently, and records of deviation of eyes since birth was not available. This is the MRD to show that. And on examination, he had both eye aphakia, right eye nucleus drop with chronic RD, extensive PVR with trough formation. And in left eye, he had nucleus drop with RP alteration. The nucleus was stuck in the mid-vitreous cavity. So this is the B scan. We don't have a picture of fundus photo, but I do have B scan. This is what a B scan photo look like. Tenting of RD with nucleus drop in the right eye, and in left eye there was nucleus drop with some PVD. So in axial length, we found that right eye it was 22.25 probably because of tenting of RD, and in left eye it was 30.94. But it was contrary to the fact that he was using +4 diopter glasses. So it was microspherophakia with myopic axial length or something else. We are not very sure of that. Right eye was operated first, and then left eye 1 month later. This is the right eye surgery. It was a triple trouble. There was nucleus drop, retinal detachment with extensive PVR. Video speed is 2 to 6x to compose more. And now, once we went inside, we saw this nucleus. I was anticipating that frag could have been used, but this came easily with cutter as the patient was young. It looked a little calcific on the examination of the same. Now the real challenge will begin how and where to start the plane of surgery. I'm just cutting posterior hyaloid face here to open up some plane for myself. Now I'm lifting the membranes. Okay, we found the plane. Now at this plane, we'll be going in again. Now I'll use my cutter to cut the field membranes, and then we'll go about the surgery further. So I use the cutter. I'm cutting the membrane, but there was all puckering of retina all around because of chronic RD. Cutting the membranes at the equator. Now I'm doing trial of reattachment with PFCL, but just to look what are the area which are not settling. Then I found the primary break, the oozing of altered SRF through the break. Now I'm trying to cut the membranes around the break and also that chronic pucker which is there. I'm trying to peel the membrane through that also. The membrane peeling was done, but still I could not see any relief in the folds. Now more PFCL was put to note all areas of non-settling retina, but now I decided to go ahead with the retinectomy. So it was prepared with diathermy, and then I used the cutter to do retinectomy. Now retinectomy has been done. So the next step, I thought that I'll do laser. Then I also decided that okay, I've come out and then I do a surgical inferior PI as I'm going to leave the IFA kit. So I went in again. Now the retina looks pretty settled under PFCL. So laser is started. I'll add only 3 rows of laser because even doing a lot of laser in these cases are harmful. So 3 rows are enough. I went ahead and to do the fluid air exchange. Now I'm not doing direct fluid air, direct PFCL and oil exchange here. I'm just drying out the edges really well so that the slippage is minimal or it doesn't happen, and it didn't happen much here. After taking out all the PFCL, I am putting oil as a tamponade. Remove all the pores. This was POD 1 and this was POD 7, and patient is still doing very well. So I'll quickly take you to the next eye surgery, which was very simple, just to make a record of what we did here. Went in with the 3 ports. You can see that the nucleus is hanging in the mid-vitreous cavity, as I told you, because of those skitic PVD, and as soon as we cut those PVD, it fell down, and maybe this is the reason he had some DOV and large floater in the central, and he came to us because he was not bothered with the right eye, what is going on in his right eye. And the remaining nucleus and the cortical pieces were easily taken out by cutter. the peripheral saving was limited to the extent possible. We did not do indented base saving here. I could do beyond equator, and I just left it. Then the case was closed. It was closed in fluid only. So I sutured the port. So on recent follow-up, I saw that right eye BCVA was 4/60 with plus 1.75 diopter sphere and plus 1 cylinder, and in left eye it was 6/9 with plus 1.5 diopter sphere and plus 1 cylinder. Maybe the oil is acting as a convex lens in the right eye. So I have decided that further intervention of SFIL we should wait, because anyways he is using very less refraction to get stable, and SFIL will complicate the things further. So I would like to proceed with any further intervention once we do SOR for the right eye. Sometimes mystery is never unfolded when there is a happy ending. Thank you so much.
Thank you so much, sir. I would like to invite Dr. Hudson for his comments.
Yeah, amazing cases. And the first case, you did the retinotomy, and
Yes,
there was
sir.
a dense PVR. Yeah, great case, because you could manage the case with gas instead of putting silicone oil straight. Many people would like just going on with
No.
silicone oil.
I did tamponade with oil only, sir. I did.
Okay, at the end of the case.
It was oil. Yeah, it was oil.
Yeah, it got pretty flat, and of course the PVR was very dense, and you could manage it and put in very flat, and that was cool. And the second case, the cataract was not so dense, so it was easier to manage it. And you've got such a good technique. There was looking at your videos, you have such a good vision from visualization from the retinal periphery. So you get almost virtually all vitreous out of the vitreous base. And this is interesting. We have to do that. Otherwise, we would increase the likelihood of getting more PVR. So very well managed cases. Congratulations.
Thank you, sir.
So Dr. Karthike, just one question from a cataract surgeon's perspective. Why didn't you do the better eye first? The patient would have been visually rehabilitated faster. Just a question.
Yeah, I actually planned the same. I did not mention that. I actually planned the same, and that person, he told, no sir, I'm able to see something from this eye. I'm not able to see properly, but I'm able to see something from this eye. So I just want my this eye to get operated first, and then I will get operated from the other eye. So if somebody told that retina, you are going to get retina surgery and all those things, he was scared of retina surgery. So he went ahead with the right eye first, and luckily he had some vision. He had almost 3/60 after 3 weeks. So he decided to go for the left eye also.
All right. And when would you plan an SOR? How long will you wait before you do a SOR and secondary fixation?
I've already planned for him. But he's actually very happy, and he's telling that I don't want SOR now. But I think he'll be coming next month or this month end for SOR.
So what is the time gap between the two surgeries?
Time gap between the two surgery was 1 month.
No, I mean between the primary surgery and the oil removal, what is the duration that you are looking at now?
First at around 4 months, because retina is very settled. I don't think that it will again be unstable after that, because there is no PVR. Even the edges look very good. So I was thinking that I'll remove after 3 to 4 months, but now it's almost been 9 months, let's say. But there is no emulsification, so that might help the patient.
All right. Dr. Karthike, very well managed. Congratulations.
Thank you, sir. Thank you.
Moving on to the next speaker, I would like to invite Dr. Divakant Mishra for his next talk. He is active part of UOC, and now the vice president of UOC. He's the director of Swarna Jyoti Eye Hospital and head of retina services at Swarna Jyoti Eye Hospital, Lucknow. He has completed his retina training from reputed eye institutes like Sri Shankardeva Netralaya, Guwahati, and Byers Eye Institute, Stanford, San Francisco, USA. He holds the post of vice president now. Welcome.
Hi, thank you so much. I'll just start sharing.
Do you want me to play a presentation?
Yeah, can you do that? I'm having some issues. It's asking me to, yeah. Please, that will be helpful. Thank you.
Just 1 second.
A 25-year-old male patient presented to us with sudden diminution of vision in the left eye. The vision was counting finger 1 meters. Anterior segment evaluation was normal. Posterior segment revealed a yellowish subretinal lesion involving the fovea. Certain relevant investigations were advised to the patient. The OCT revealed a large hyporeflective cystic lesion along with a hyperreflective wall with something that looked like a scolex attached to the wall of the cyst. Rest of the investigations were unremarkable. So clinical diagnosis of subretinal cysticercosis was made. Patient was put on oral steroids and vitrectomy was planned. 25 gauge 3 ports were made. Core vitrectomy was performed, and if you notice keenly, the classical undulating movements can be observed here. PVD induction was tried first without triamcinolone. Then triamcinolone assisted PVD induction was successfully done and a complete vitrectomy was performed. After the removal of vitreous, we could see a macular hole that had also developed. A small retinotomy was made at the edge of the cyst to access the subretinal space. Through this retinotomy, active extrusion was used to bring out the cyst in toto. The macular hole was more apparent at this stage. The highly compressible nature of the cyst can be appreciated here as it is removed totally through this small retinotomy. This prevents any collateral damage to the surrounding retina while its removal. Then the cyst was eaten up at high suction and high cut rate with the help of the cutter. Fluid air exchange was performed. The subretinal inflammatory debris and the SRF were carefully removed from the retinotomy that was made earlier. SF6 gas was then injected, and after that the patient was advised to maintain prone position for another 1 week. So we got good outcomes after the surgery, a vision of 618 and the hole was closed.
Excellent. Over to Dr.
Everyone. I would like to ask Dr. Hudson if he has any comments on the case.
Yeah, you know that you see this kind of pathology here in Brazil very common, and we've got some cases pretty much like yours. Unfortunately, the cyst is right on the macular area, but very well managed. I will do the same as we did here with some cases, and we do some retinotomy, a small one, and grab it, and then the cutter does the rest. And that case I saw, it was presented in Retinosome like 2 years ago by Natarajan. Natarajan showed a cool case as yours, very well managed and ended well. And congratulations. Did you send the patient for low vision as to try to restore some of the peripheral visions later?
The patient was maintaining relatively good vision. We got around 618 vision. So he was pretty happy with that vision. And now we have lost the patient to follow up. So, yeah.
Yeah, congratulations. And beautiful images.
Thank you. Thank you.
Yeah, Dr. Divakant very well managed. It was good to see an interesting case, because we don't get to see so many of these lovely retinal surgeries. I just wanted to know, you did a small retinotomy there to drain out. There's no need to laser around the retinotomy there, or?
Right. So that is, the house is divided on that. So wherever I present, a lot of people have the same discussion. But this worked out well in this case. It's the the retinotomy is very posteriorly located. So usually we do not need to laser these. Had it been a bit peripheral, then we would have definitely lasered it.
All right. And the nitrogenic, that small hole that was there, because I'm not a retina surgeon, I don't know, but could you have peeled off the ILM under air or maybe under, PFC, fill it up?
I had considered it, but the retina looked very fragile at that moment. So any further maneuvers would have damaged the retina more. And usually the peeling and all helps when the component is more of, tractional component is there. So in this case, it's more of, I think, inflammatory or maybe iatrogenic, which has led to the hole. So we didn't do any extra maneuvers for that.
All right. Beautiful case.
Thank you so much.
So can we take a few audience questions?
I think we'll do that we'll do it in the end.
Later on?
Yeah, later on, last.
Yeah. So I would like to introduce our next speaker, Dr. Karan Bhatia, who actually in this group, I think requires no introduction. He is a very active member of our Young Ophthalmologist Society of India. He is a very prolific cornea surgeon, having done his fellowship in FECO from Venu Eye Institute and his lamellar corneal surgery course under Dr. Rajesh Fogla at Apollo Hospital, Hyderabad, and a fellowship in cornea emulsification and refractive surgery in the Joshi Eye Institute. He's a very, very hardworking person, one of the most active people in UC, and it's my pleasure to introduce Dr. Karan Bhatia. Please, sir.
Thank you, sir, for the kind introduction, and thank you, Aditya and ADH, for this opportunity. I'll share my screen and get straight to my presentation, which is the mixed technique, which is a novel approach for sclerafixated IOL implantation. So I have no financial interests in what I'll be presenting. So the ideal situation after any cataract surgery is a clean phaco and then the implantation of a IOL into the back. However, it doesn't always happen, and what we do have is surgical aphakia. So various options are there. We can have the anterior chamber IOLs or the retropupillary iris fixated IOLs and the sclera fixated IOLs. Sclera fixated IOLs are the most popular approach worldwide, and various surgical approaches have been described from it, from the suture to the glued, Gabbers, Yamane, and the X-nit techniques. So, but it's always a challenge for the anterior segment surgeons. So we came out with this technique called the mixed technique, which is a modified adaptation of the Yamane and the X-nit techniques, where the externalized haptic is cauterized to form a flange like the Yamane technique, and the needle, the 26 gauge needle, is brought out of a sclerocorneal tunnel, and that is when the proline haptic of a three-piece IOL is introduced inside the needle lumen, like the X-nit technique. So therefore, M stands for modified adaptation, Y for the Yamane, and X for the X-nit techniques. So we published this in the Indian Journal of Ophthalmology, and we got the AIOS IGO Silver Medal Award for this publication in 2022. So let's take a look at a case. This is a 55-year-old gentleman with an uncorrected visual acuity of 1/60, post-cataract surgery aphakia, and you can also see that there's a superior peripheral iodectomy. Just a second. Yeah. So, yeah. So, like a small incision cataract surgery, what you would want, you want to make a phonic space flap and then a sclerocorneal tunnel. Here there was a buttonholing from the previous surgery. So you make 4 marks over here. Mark 1 is oriented 2 millimeters, 180 degree. And then mark 2 is on the other side, 2 millimeters from that. And then you make mark 3 and 4. Mark 3 is 2 millimeters below mark 1. And mark 4 is about 2 millimeters above the mark 2. So this is how I'm making the marks. So this is a very low cost technique. It doesn't cost as much. So this is a PVC stopper that we had made by cutting the IV set. An AC maintainer was used over here. So angle transconjunctival sclerotomy is done by a 26 gauge needle. And this needle is brought out like the X-nit technique. And then this 3-piece IOL, which is a PMMA IOL, costing about only 160 Indian rupees, is introduced. The Prolene is introduced, and this needle is brought out slowly out of the sclerotomy site, and the stopper is applied. And similarly, you would do it on the other side via Mark 4, an angle stance conjunctival sclerotomy. Then this needle is brought out of the other side of the sclerocorneal tunnel, taking care not to damage the iris. And once this is done, you can use this haptic and put it inside the lumen of this needle. This is slowly brought out. This is when you turn your AC maintainer off. You can also use past vena infusion also if you're a VR surgeon. And then you need to titrate this IOL. So the centration is titrated over here. And once you get the right centration, then I like to trim the IOL to get a good taut fit, because it also prevents pseudophacodenesis. And then that is when you cautery it using a Bowie cautery or a heat cautery. And this, you create a mushroom shaped flange. And this flange is actually buried intrasclerally. Subconjunctival, then intrasclerally. Similarly, the haptic is trimmed on the other side, and you create a flange. Sorry. And this flange is also then buried intrasclerally. So it's a very easy technique. It just takes about 10-15 minutes, and then you suture your tunnel. Because it's a vitrectomized eye. The thing is, yes, you need to do a good automated vitrectomy before it. Manual vitrectomy is not an option over here. So this is how this patient did very well. So a couple of recommendations is that the AC maintainer or a past vena infusion does make life easy. Initial cases I did just under HPMC, but this does make the life much more easier. Then the creation of an eccentric tunnel. So the tunnel should be slightly on the right side over here. So this is where, because the trailing, the second part, when you put the needle out, it doesn't come out. The needle is quite a little bit shorter. So when the tunnel is directed a little bit more towards the right side, it becomes much more easier. Then a jugaad or a low cost thing that we use is we cut this IV set, and this you can use iris hooks, the stoppers of the iris hooks as well for this, or you can use a silicone sleeve as well. But this is what we had used, and this can be worked as a stopper. So this is the plastic stopper that was used, and it helps to prevent the slippage of the IOL. I've also combined these cases with keratoplasty. So this is the case of a 23-year-old one-eyed post-trab eye. He was dependent on others for the simplest of tasks. So there was a thick fibrotic desmoid membrane. After peeling of that, this is how it came out. It was a long surgery. And then since this was a post-trab eye, instead of making a sclerocorneal tunnel, I actually went ahead and did it via clear corneal incision. And you can see over here, similarly, in the same way, I'd speed through this video. The IOL was put, and then the flanges were made. And once these flanges were made, the IOL is very well centered. And the next step was a DSEC that I had done in this case. This video did get selected for the CS Reshmi finalist session in AIS 2022. This was a DSEC graft, a manually prepared and ultra thin DSEC graft. And this was unfolded, and then during the needle insertion technique, this was put inside the eye. And using tapping movements, this like you would do in a DMEC case, this was unfolded since the graft was very thin, and air was injected to put it in place. So this is how this patient did. Day 21, this is what he looked like. An uncorrected visual acuity of 6/36 and 67. It improved. BCVA improved to 618 plus 2. You can see how clear the graft is. The IOL is very well stable. The flanges are very nicely intrascleral buried, and you can see the graft size is about, the DSEC graft is about only 57 microns. So this patient became independent and running and was doing very well. This is another case, 35-year-old one-eyed, corneal opacity, with vascularization. So this is an open sky I have done over here. So I prefer to do a lot of combined surgeries myself. In this way, again, the needle was brought out over here. The same marks were made, but this is much more easier. The only thing that we had to watch out for a suprachoroidal, but the IOL was very well stable. Again, same thing was done. Angled transconjunctival sclerotomy was done using a 26 gauge needle, and then again this was the haptic was introduced into the needle lumen. And then this IL was also brought out. And you can see over here, the haptics were trimmed, flanges were created. And you can, again, in the same side, and on the other side, the same thing. You can see how centered, well centered the IL is. The flanges are also intersclerally buried. The next step was to complete the keratoplasty, which was done PK in the normal manner. You need to trim this because if you don't trim the haptics, what happens is that there's extrusion of the haptics. That's when we decided that you need to trim it accordingly to the eye. This patient also did very well. However, there was an LSCD. So then he was, however, lost to follow up. So mixed technique is an easy, fast, reproducible technique, which has advantages of both the Yamani and the XNIT techniques. Thank you so much.
Yeah, really, really good technique. Let me ask you, when you have the IOL stable in the anterior chamber, I saw in the video that you close the infusion. But when you close the infusion, if the eye gets a little soft, would you put some visco inside or just leave it like that?
No, I would put visco inside if it's getting too soft. But the thing is, I'm confident in my tunnels. If the tunnel is going to be leaky, then you do need some kind of support. But if the tunnel is okay and fine, then if you turn off the infusion and everything is already inside the eye, it won't leak that much, and you do it pretty quick. Yeah. So.
All right.
So Nikunj had a big role in this as well. Nikunj is also here in the panel right now, and he was one of the speakers. We both had brainstormed this a lot, and we've done about a lot of cases and with excellent results.
Karan, nice to see well-managed, complicated case. Couple of things. One, what's the difference? The only difference that I see is that you're using a fixation for the externalized first haptic before melting it, and that helps in sort of titrating it. Is that what the difference is?
Titrating and slippage.
Slippage. So, but why not melt it in the first place?
Because then you have to grab it. You can melt it, then you have to grab it, and then you have to cut it again. So what I use is the Aurolab 3-piece lenses only so far. These lenses are very cheap. So where I was working, it was a community center or a charitable hospital. If I'm going to ask a lot of money, the patient will not do it. And we are doing these surgeries mainly, you can say, at a charitable rate or almost free. So you need to take care of the account of the cost of the IOL also. This is about 160 rupees. That's about $2 for the IOL. That's nothing.
My question was, when you externalize haptic 1, so you were fixating it using a stopper. Rather than that, just melt it away so it sort of locks into its place.
But you need to again hold it and then trim it again.
Yeah.
If you're using this IOL, that's the thing.
All right. And what's the needle? What's the fit of the needle?
Normal 26 gauge needle.
26 gauge needle. All right. So that's why I wanted to know, because it looks like a very elegant Yamane, except you are titrating it before melting it away.
Yeah.
Great.
Karan, congratulations and for all these innovations. I just want to know, what's your longest follow-up of these surgeries that you've done on many very complicated cases? So you've done this kind of fixation in eyes where there's corneal opacity. What was the reason for corneal opacity? These kind of innovative scleral fixation procedures, I'm not too sure where there's scleral thinning. These are the eyes which are diseased. And when the cornea is this bad, in all probability, the scleral melting and those issues are,
So you need to, ma'am, choose your patients very carefully over here. If there is scleral thinning, this is not the way to go for it. This patient has a follow-up about the DSEC case that I had showed, has a follow-up of more than 2 years. He is doing still the same. He is doing very well. He's independent. He comes every about 3 or 4 months or 6 months for a checkup. I have moved cities. So I have lost follow-up with a lot of my patients, but there are good reports regarding that. But these keratoplasty patients who have done combined cases, they do come again and again. The second case, the OPK case that I had done, I wanted to do a slit with that, but then the patient was lost to follow-up.
I just wanted to tell all those young ophthalmologists watching that when there are corneal issues, you have to look at everything and you have to be a little more careful with these procedures. But wonderful.
Thank you, ma'am. Absolutely, you're absolutely right. You need to look at the eye as a whole, and that's very important.
Excellent. I think we move on to the next talk. Excellent talk. Our next talk is by none other than Dr. Nilesh, who's at the airport and who's ready to tell you what lies beneath. The perfect title before you catch a flight, isn't it? So I'll share his video.
Welcome to Instructive Constructive, where we discuss full-length surgical videos that are being normal or have some complication. These are performed by me. I'm Dr. Nilesh Kumar and I work at Madhvi Netralaya. And today we are going to discuss what lies behind the veil of a white cataract. So a routine white cataract, it seemed, and we started making with two side ports 180 degree apart, and then the main port incision 2.4 millimeter incision that was made. The capsular staining was done. The side ports were marked with the same stain by some leak, then viscodispersive, and then some viscocohesives to make a soft cell technique. And then we started with circular rhexis. The soft cell technique prevented the Argentinian flag sign, as the cataract was not too much intumescent, so it didn't happen. We were lucky for that. And then a little bit of hydro procedure. We try not to do too excessive hydro procedure because we don't know what is the status of the posterior capsule in these cases. So we start with the phacoemulsification. In the sculpt mode, I tried to aspirate the cortical matter that was present above the nucleus, and then I tried to hold the nucleus some air bubbles, so I tried to remove that, and then while holding, the nucleus stood up. This should have been the first sign I should have noticed, but I missed it completely. Again removed the air bubble with some aspiration, again tried to hold the nucleus, but it was not getting held as firmly as it should, but still I was able to do some amount of chopping. Removed the nucleus and then again tried to hold it. Again I am seeing it is getting dipped. Now I think there is something that is not right, but still I go ahead, and then I try to bifurcate the nucleus, but as I notice, the nucleus started to dip behind. At this point of time I should have injected viscoelastic, but the mind didn't work because there was a PC rent staring at me. And I would like to suggest that if something like this happen, pause for a while, take a few seconds, formulate a plan before right away jumping into the situation. So then I put some viscoelastic. Now my plan was to do a past planar infusion and get the nucleus freed, because the nucleus can go behind, and by the past planar infusion the flow will keep the nucleus afloat and into the AC. Now one more mistake I did was I didn't flush away the air that was present in the irrigating port, and you can see the air bubble is pushing the nucleus behind, but I was lucky that I didn't push it completely into the vitreous cavity. And as soon as I start doing the vitrectomy, the nucleus again I can see is staying in position, not where I should like it, that is in the back, but at least in the pupillary area and in the anterior chamber, anterior plane where I can access it. And as I start doing vitrectomy, I can see the nucleus moving quite freely, so I anticipate there should not be much traction to the vitreous base and the retina should be fine post the procedure. So I started freeing the nucleus from all the aspect, and when I am pretty sure that everything is good and I can move the nucleus freely, still I do a tricot staining. For beginners I would suggest that the tricot staining should be the first step, but with a little experience I could see the vitreous, so I didn't stain it in the first, but to make sure that the nucleus is free from all the entanglements of vitreous, I stain it with tricot in the end. and now I am pretty sure that the nucleus is completely free. Now what I do is to proceed with my plan of doing an IOL scaffold before emulsifying the nucleus and taking it out. There are multiple ways from here where we can go. There we can enlarge the rhexis and take it out via an ECC wound, but with the new machine that I have got, mind you, the entire process is being done by the Zeiss Quattro 700, and the infusion and the vitreous cutter is from the same machine. So with this machine I am pretty confident of the AC stability in IOL scaffold techniques, so I prefer to do that. I start with injecting the IOL into the sulcus. The leading haptic has gone in, and now the optic is being tugged inside, and from the side port I would just dial the optic into the anterior chamber, and then behind the iris into the sulcus. A little bit of iris prolapse is seen, which I had anticipated because there is too much into the AC to be held. The entire nucleus is into the anterior chamber. There is some viscoelastic, and then the optic is also just above the IOL rim, the capsular rim. So now we start with phacoemulsification. Then iris is prolapsing from the main wound, but I'm not much worried about it because I'm not going to go too much in and out of the anterior chamber. The IOL probe, once entered, will emulsify the entire fragment. This video is being played at 2x, so this was happening half as slow as it is being shown, and the entire nucleus is emulsified within 20 seconds. So I don't anticipate too much of iris damage with this new machine. Now again injecting the viscoelastic and seeing that the IOL is in place and firmly secured, and then I hydrate the wound. My first plan was not to suture the wound and see that the AC is holding, but as soon as I start doing a visco wash, I see that the iris again prolapsed and there was a leak. So then I thought to suture. Now mind you, there is another way of doing the suturing, that is to fill the AC with viscoelastic again and then do the suturing, but again then it will require a visco wash, and it might lead to iris prolapse again. So I thought that let's avoid that. So I do suture which has no traction. There is no DM fold, so that when the AC inflates, it is not going to cause too much of astigmatism. Now we tuck the knot of the suture into the sclera. It is tucked in very good, and then we hydrate the side ports again. The AC is formed, and I see that the AC is completely stable. So then it is very important to see that the AC doesn't collapse when we remove the speculum. And this is the POD 1 week picture of the same patient with an uncorrected visual acuity of 612. Thank you for watching.
So any comments from the panel? Dr. Shikha ma'am, what is your choice of what would you prefer to do when you have intermittent cataracts? Dr. Samrish?
Yeah, no, Dr. Shikha is here.
Ma'am.
Sorry, Aditya, I couldn't see the video properly, so I didn't disturb everyone because I saw that everyone else was watching, but I could hear him. The video was not playing. Even Karthikeyan's video, actually, I couldn't see. When you play from your laptop, I am not able to see. I don't know. So anyway, from what I heard and I saw, the initial part which I saw, why did we land up with this rent, Nilesh? Before we go to the later part of the IOL, I just want to know what was the technique which was being used for the nucleus management? Nilesh, I'm talking to you. Are you able to hear me?
Yeah, ma'am. Am I audible? Yeah. So, ma'am, initially when I
Yeah, Nilesh.
So, initially, my preferred technique for nuclear chopping is a
Aditya,
direct
even
chop,
you are
and
muted. I can't hear Nilesh.
Ma'am, can you hear me?
Everybody else can hear. I'll come on phone otherwise.
We can hear, ma'am.
I think. Samresh, you
Yeah.
carry on.
Sure, madam. So, Nilesh, again, it is a nightmare for anyone. Okay, it's not even in the best of hands, it would be a real nightmare, and you manage it very well. Again, like I discussed initially, once if you don't know what's happening and there is a compromised anatomy, I would always encourage you to use triamcinolone so you can see the vitreous. Okay, I think you did the right thing by putting an infusion and trying to see. But if you could make a pars plana infusion, you could have done a pars plana vitrectomy. Because you would have more access from posterior, because you don't want to drain the vitreous up, you want to pull it back down. So that would have been a good thing. The other thing I didn't understand is because we couldn't see the bag in any point, where the PCR was. So it was quite a leap of faith putting that sulcus implant behind all that nuclear material.
Actually, the video, I think the video is not showing it. The resolution was not that good, but I could see the capsulogram very well. The entire PC was absent. So I think there has been some trauma. The patient was, unfortunately, he was handicapped. He had one leg amputated. So I think there had been some trauma initially, which went unnoticed.
Nilesh, we got to stop here, Nilesh. You did quite a bit of phaco. It rotated and this. If there was a trauma, it would no. I don't think there was a trauma in the video. It was seen very clearly at which point your probe went and directly touched the PC. What was happening is that the nucleus was not. You were trying to do a chop. It was a direct chop kind of thing that you were doing, and the nucleus was, every time you were going there gingerly, the nucleus was moving, rotating. So in this situation, if you're not getting an exact, at no point you got a good grip on the nucleus. You never caught hold of the nucleus completely. So you divide the pieces. So in such a situation, I think if it's rotating like this, you're not able to get a good grip. It's better to do a divide and conquer. If it's like, dangling. This happened because the nucleus was, you're trying to capture the nucleus, it's completely rotating. And the part where it was split into two, from that gap your probe tip has hit the PC. It was not a traumatic cat. You wouldn't be able to do so much of manipulation. Before the rent developed, you had gone around a lot. So you got to change you have to be careful about the technique for nucleus management in this case. That right from the beginning, I found there was a problem.
Sure, ma'am. I'll review my video because
I mean, like probably you were a little more experimental because you knew that you can manage whatever it be. All's well that ends well. You at the end of it, the patient did well. Yeah, but if anything can be done to prevent it, it should be done. I noticed that this is where the things were going wrong. Yeah, Samresh, you carry on.
Sure. No, I think he brought it about nicely and he managed it very well. I think one more point for all the junior doctors who are listening out to us is, if you have a vitreous loss and you put an IOL in place, it's always best to suture, because you want a watertight eye. You don't want any leakage, any hypotony causing more vitreous prolapse. Since you've not done a full vitrectomy, you've only done a partial limited vitrectomy. So I think even if you think your incision can hold, it's best to suture it off. So with that, I think very well managed, Nilesh.
Excellent, well done.
Thank you, sir.
And have a safe flight.
I have
Wherever
one
you go.
question
Have a
to
safe
Nilesh,
flight.
if I can ask. Nilesh, you had increased the wound size a lot. I know for 3-piece you need to increase, but a lot. So how did you, the settings, because you went ahead with the same port, what were the settings change in the phaco parameters that you had done? Because that would
with the new Quattro so there is a setting, whatever leak is happening is being compensated by the machine. So whatever leak is happening, like in this around 80 ml fluid leaked through the entire process, and 80 ml was compensated. So my I just had to set the IOP to 35, and the aspiration I kept it around 45 or 50, and then I went ahead as usual.
45 is too much aspiration. If you're trying to save an eye, I mean, like it's not a slow-mo phaco. If you're trying to say 45, 50 aspiration is like good aspiration, and that too with a bottom height of, you said IOP of 40, right?
35
IOP with an aspiration flow rate of 45, 50. I mean, like it's like.
Ma'am, once the IOL scaffold is there and this machine has an IOP, the flow rate setting of like I operate in around 80 to 90.
If you're trying to do something different to better your fluidics, then this is like you are at the extremes. You have reduced the IOP, usual IOP at which you were talking about the IOP, right, in Centurion.
Yeah.
So when you're trying to reduce the operate at 30, 40, IOP, it's on the lower side. And if you're using the and your aspiration flow rate of around 50, it's on the higher side. It's like a good fast phaco kind of a thing with a low IOP. You'll have lot of surge and lot of movements. You had the scaffold, that's fine, but you can do it. I'm not saying that it cannot be done, but if somebody is trying to do something about the fluidics, you're trying to make it slow-mo and a safer phaco. If you have a leak, especially, I think Karan asked because he said that you had enlarged your wound. So in such a situation, you increase the, you can lower aspiration flow rate is around, 30, 25. This is it. Like 50 is double.
I'll try, ma'am, but in my hands, I feel faster aspiration works well because I don't have to like, yeah.
Fine.
Thank you, ma'am. Thank you, Nilesh.
Thank you, sir.
Close the session. So I would want Tushar to take over.
So I'd be happy to introduce Dr. Subhojit, who's of course a brilliant pediatric ophthalmologist, also a brilliant guitarist and a brilliant singer as well. So let's have his presentation, which is called Video Bouquet of Pediatric Traumatic Cataract Surgeries.
So kind of you, Tushar. Good evening, everyone. It's an honor to be a part of Pan Ophthalmologica, and it's a real good feeling to meet all my friends and Karan, Aditya, and Nikunj as well. Tushar, you, Advait, and of course, it's good to see ma'am as well, Shikha ma'am. So, so today I've been given an opportunity to demonstrate a few different varieties of pediatric traumatic cases. So I'll just go ahead directly with the slides. So as we know, I'll just make it full screen. So as we know, every trauma case has a different experience, and it's always a unique challenge for each and every case, and innovations needs to be made. And I'll start with, I have 3 cases to demonstrate over here. I'll start with the case 1. So this was a 6-year-old boy with a history of a 3-month-old penetrating trauma repaired elsewhere, which has developed a thick corneal scar along with a membranous cataract and a dense posterior synecdoche. So I went ahead with the cataract and the challenges over here. The first challenge was the IL power calculation. As we see, IL master works in most cases. Alternatively, pentacam K values can be used, and if not, other I K values are also can be useful. And of course, the visibility is a challenge along with planning of the corneal ports accordingly and retaining the capsular support and the IOL insertion. So the first step is always the release of the adhesions. So as we can see over here, a high molecular weight OVD was used, and gently we try to release the dense posterior synecdoche from all sides. We could see some corneal adhesions as well. So the pass was also tried to be released as much as possible. And once the adhesions were released, then we had put some iris hooks. Ports were made accordingly to the sides of the corneal trauma, corneal scar. And as we can see, after the proper exposure, the underlying cataract was properly visible. So the next step would be clearing of the visual axis. So in this case, there was no anterior capsule as such. So I tried to do the rexis, but it didn't work out. The AC and the PC and the cataract was all joined together. So we had to do the entire thing with the cutter itself, with trichotomy cutter. And in this case, a port was, the opening was made with the cutter with port down, and it was increased as we went on. I'll just decrease the volume. So an opening, we tried to create an opening of around 5 millimeter radius, and care caution was maintained to keep the capsular rim intact. The peripheral cortical matter were also teased out with the help of IA. And at the end of the cortical wash, as we could see, the capsular rim of around 5 mm could be preserved. Just a sec. Yeah, so yeah, around this length, 5 mm, this could be preserved. So coming to the IOL implantation. So a 3-piece IOL is, of course, is always planned in such cases. And as we go ahead with the 3-piece IOL, it was placed in position. And then the hooks were removed. And finally, this was the final picture. The pre-op vision was hand movement close to face, and the post-op after a month, the base corrected vision was 612. I'll quickly go on to the second case. This was again a different variety of a trauma case. It was a 7-year-old boy with a dense posterior synecdoche along with a membranous cataract with a thick fibrous anterior plaque. Vision was again hand movement in this case. So the challenges in this case was the dense synecdoche release, the plaque management, followed by the capsular rim formation and the IOL insertion. So the synecdoche was so dense that I had a really hard time releasing it underlying, and gentle caution was to be caution was maintained so that I didn't damage the root of the iris, creating an iridodialysis. All the adhesions were cut off and iris hooks were inserted. So this was the final picture, which showed the underlying menacing plaque. So followed by which I tried to create a nick in the plaque, but however, it was thickly adhered to the underlying cortex, and AC and PC all was conjoined. So following which I just had to put a nick on one end and a plane of separation could be identified. So the plaque was tried to be separated from that area, and where the areas were too adhered, it was cut off with a long scissor. Caution was maintained to preserve the capsular rim. And finally, the plaque was released, and care was maintained to remove all the vitreous adhesions from the underlying vitreous cavity. And so this was what it looked like after removal of the plaque. Following which, the cortical cleanup and anterior vitrectomy was done. So the capsular opening was enlarged with the help of vitrector itself, and along with anterior vitrectomy, which was done. The other side cortex was cleaned as well, and care was maintained not to drop any of the fibers under. So this is what it looked like. Following which, we put the 3-piece IOL into the sulcus and dial into position. So the hooks were removed, and this was the final outcome, which was quite satisfactory to the patient. I have one more final case to present, and this was a four-year-old boy with a traumatic cataract with a 2 clock hour iridodialysis and posterior synecdoche, and anterior capsular rupture was there. So the challenges was the synecdoche release along with management of the ruptured anterior capsule, and along with vitrorexis, I did retro IOL, and an iridodialysis repair was done at the end. So the first step was removing all the adhesions, and following which exposure was done with the help of hooks. So this was the underlying cataract. The extent of the capsular rupture could be seen. Following which, the nick was given at one end of the capsule, broken capsule, and it was peeled off with like a rexus. And once we reached the other end, we could see it was thickly fibrosed. So the other end was cut off with the help of a scissor. So the cortical cleanup was done after that. The capsular opening, irregular capsular opening was enlarged with the help of vitrector itself. and the loose cortex was aspirated on both sides. Capsular polishing was done as much as possible. So this is what it looked like after the cleanup. And finally, the 3-piece IOL was placed in the sulcus and dialed into position. So next we had to deal with the iododialysis. So this is again, yeah. So this was the, this next we had to deal with the posterior capsular opening. So I had to go behind the IOL and a retro IOL capsulotomy opening was done with the help of the vitrector itself, and an approximate opening of 5 millimeters was created along with a limited anterior vitrectomy. So finally the step of iododialysis repair was there, where the initial assessment of the repair was made. It was almost around 2 clock hours. So I followed the railroad fashion technique. A 26 gauge needle was inserted from the sclera and through the eye root of the iris, and from the other side, long end of the 10-0 proline suture was inserted, and the same procedure was repeated in the form, and the loop was formed. Since it was just a single suture, I didn't make any tunnel over here. I just buried the knot under the conjunctiva. And so the pupil size was titrated accordingly once the loop was tightened. And this is how it finally looked like. The post-op vision was satisfactory. So that's it. Thank you so much.
Thank you so much, Subhajit. I'm sure Tushar has some questions to ask. I'll ask him to collaborate all his questions with the next talk, after the next talk. We have Dr. Nishant.
Just a second. Yeah, I sorry, I just put my audio on mute. Just come again.
We have questions for you in the pediatric session. You have to wait for the next talk and then we'll ask you questions. So
Fine.
Yeah.
Fine.
So Dr. Nishant again is a celebrity cornea cataract refractive surgeon in Chennai. He also gets offers from Bollywood and Collywood, but so far he's stuck to ophthalmology. So let's hear from him.
Thanks a lot, Tushar, Aditya. Subho, I think you should stop screen share. And you didn't acknowledge being happy to see me.
Subho,
screen share.
Yeah, sorry, Nishant, you were not there at that time.
No.
Screen share, stop screen share.
Yeah, just a sec. Yeah, just a sec. New share, yeah, just a sec. Yeah.
Thank you, everyone. So yeah, a very good evening to all. Thanks, Pan Ophthalmologica and Advait, and I'm sorry, Aditya, for giving this opportunity. So I'm going to talk about a refractive procedure called the TREC. So we all know that keratoconus, what it was before, was always treated by the routine collagen cross-linkage with riboflavin with what we do, and the patient should either wear contact lenses or glasses to stabilize the cornea. Now, we had a paper published by Dr. Shetty et al., where they used to do a topography-based removal of the cornea epithelium and the stroma with a trans-PRK method. So what I did differently was a PRK combining with C3R. Yes, we all know that we already had this TCAT CXL, where we used to do a topo-guided treatment for the cornea. But the only disadvantage what happened was we used to ablate a lot of corneal tissues. So minimum the patient should have a pachymetry of above 400. So even plan for this topo-guided treatment. This is a very unique procedure where you can ablate even 10 microns or 5 or even 15 based on the thickness. So as you can see that this patient is a case of keratoconus. So we take the tangential anterior. The indices for keratoconus were high and the thickness was around 470. So what we do with this procedure is mainly done for early keratoconus, where the thickness should be above 350 at least, and no any apical scarring. So we take the tangential anterior, and what we do is we see the thinnest pachy and we take the measurement of the cone alone. So we all know that the steepest part of the cone is what which is showed as red over here. And any laser or any excimer is going to flatten it. So what if we can flatten only the cone area and leave alone the rest of the corneal tissue, which is not so steep? So you can see that the calculation is around 3.6 millimeter, and this is 2.85 with a thinnest pachy, which is showed in the map. The Schwind Amaris has the software where I can actually put the long and short axis, the offset of radius, which is the most important, where it is not only the center, you can decenter wherever you want of the ablation. And you can see that the depth which I have put for this particular patient is around 20 microns. So as I showed you that this is what the topographic based topography is of the patient of the steepest area. And look how perfect superimposition of the Schwind Amaris where you can have where the laser is going to be applied. So this is a small surgical procedure where I manually scrape off and remove the epithelium because the microns change. As you can see this superior part, you can see the red dots where the lasers are being fired only in that place where the cone is there. You can see rest of the cornea is not ablated even while the laser is in the center. That is, the pupil centration is still there, but the laser fires it in a defocused way. So I don't do put any mitomycin, but after this, because I don't mind a scarring happening later on. And then after this, a routine riboflavin with, I do the 10-minute for the UV rays. So we have actually had around 16 eyes till now. I'll just go ahead with few cases where we take the logmar, the Kmax, and the SIF. SIF is nothing but the symmetrical index friend. Doing this procedure, I'm not going to say that the patient is going to be glass free or contact lens free, but the cornea gets a little more regularized where later on their vision might improve and the fitting of these RGP lenses or rose-K lenses will be much better. Case 1, you can see the one which is on top is the one which was pre-operatively, where you can see the SIF is almost around 9.3. Where after the trek with C3R, you can see that it is drastically reduced to 3.27. Even in the Scheimpflug image, you can actually see that the regularity of the cornea is much better. Inferior was around 64 of the K value, which is actually reduced to 57. So there's a drastic increase. And you can see that the K value in the 3 mm and the 5 mm zone, which was initially 66 and 64, has come down to 62 and 59. So we are just regularizing it by flattening one area, which invariably steepens the other opposite area. So that patient's pre-op vision uncorrected was 3/60. After 6 months, it did improve to 624. Yes, with a little bit of cylinder, but it is much reduced than what it was pre-operative. So this is the second case, which I want to show. The one on the left is the pre-operative, and post-operative, as you can see that it is drastically regularized the cornea. So by this method, even the spherical aberrations and all the higher order aberrations get reduced. So the patient's clarity of vision, the patient acceptance to glasses will also be much better. You can see the SIF has drastically reduced, and which was 2/60, improving only to 6.9, has actually improved with a little less amount of power of cylinder where you can give it with the glasses, where the patient is improving to 6.6. And this is my final case, which I want to show where you can see the improvement which is there. And the symmetrical index from 4.51 has reduced to 2.28. So we have done a pre-op and post-op mean, and you can see that p-value is significant in the logmar, the SIF, and the Kmax value. So we know that it is statistically significant. So how does this be different from a TCAT is what I told you, that it decreases the impact of corneal irregularity by improving the visual performance, a better chance of contact lens fitting, and people who are not being able to improve glasses are able to see better with glasses, and partial correction of refractive error as well. So this is my case list of so many people where pre-operatively and post-operatively they're doing really good, where they are able to see much more better, and even RGP lens fitting or rose-K lens fitting is much more better. So this is an amazing technique which is used for keratoconus, where you flatten the steep mountain. Thank you so much.
Excellent, Dr. Nishant. Dr. Samresh, one quick comment, and Dr. Tushar, one quick comment. You both have 30 seconds each before we move on to our next session.
Yeah, okay. So in the interest of time, Nishant, again, this was very well managed. These are very gray zones. I have experience with topo-guided PRK, but I've obviously, you're the second person who's showing me Trek. I've sort of Rohit's work. And I think what you brought about is nice. You don't want to treat the cone, but you want to convert an irregular cornea into a more regular cornea. So like your second and third cases are super striking. We went from coma to total astigmatism, which is why the patient improved best corrected vision. So I think there's lots more of this to be seen, and great job putting it up. Thanks.
Thank you. Thank you. Very true. Yes, I learned from the master himself. So I am actually doing it because it works. So I'm sure that, but as you say, I cannot assess how much of cylinder is going to be corrected. You'll be shocked that from minus, they might go to plus as well. So that is not under our control, but yes.
Excellent.
Summarize.
So I think this is a wonderful alternative to topo-guided PRKs, and it's giving extremely good outcomes. So I think we'll know more about it soon. But if I'm not wrong, Nishant can clarify. You can also do this in slightly thinner corneas compared to topo-guided PRKs because you're shaving off very little of the cone here. So I think a great alternative in those cases also, which are probably just a little thinner than what you would do a topo-guided PRK in.
Exactly. So that is the one of the advantage where you can do it in. That's what I keep my cutoff at 350. So below 350, I don't do any excimer procedure.
Thank you so much, everybody. I would love to thank our exquisite panel and great speakers. Please stick around. Next is even more fun and more educative. Dr. Shruti will take us to the next session.
Oh,
yeah.
Yeah. Shruti, go ahead.
No. Close yours, Ketki.
Decide soon.
Decided. A very good evening to all again, and welcome to the pediatric session of the Pan Ophthalmologica. The topics here are very interesting, and I would let Shruti introduce the panelists first.
Yeah, hello everyone, and welcome to the funnest session of Pan Ophthalmologica. And I thank Dr. Aditya for this wonderful meeting. So for kids, so Child's Play No More is it's a panorama of the modern concepts of pediatric ophthalmology and new notions that we're going to be discussing today from all the stellar speakers. We have a wonderful panel spanning all the way from north of India to the south. We have with us Dr. Pradeep Sharma, the doyen of pediatric ophthalmology from Center for Sight in Delhi. We have with us Dr. Suma Ganesh, who is the head of pediatric ophthalmology from Dr. Shroff's Charity Eye Hospital. And she's greatly experienced in complex strabismus and cataracts. So she will be here with us to moderate the session. We also have Dr. Sumita Agarkar, and she's the Deputy Director of Pediatric Ophthalmology at Shankara Netralaya. She's my mentor and she's a wonderful teacher. So we're going to be having some interesting discussions from the panelists here today. So we look forward to an exciting session, and over to Ketki to have the tough task of introducing the doyen of pediatric ophthalmology, Dr. Pradeep Sharma.
Thank you, Shruti. I'll try. It is a great honor to introduce Professor Dr. Pradeep Sharma, sir. Although he needs no introduction, I'll make a humble attempt. He's the guru of all our gurus. He's the one who has simplified strabismus for each one of us. His passion for pediatric ophthalmology and strabismus, combined with his affable personality, has made him a global luminary and in strabismus from our country. He is the only Asian to give the NAP lecture at APOS. We are very fortunate to have him here, and I welcome him on behalf of Pan Ophthalmologica team. Welcome, sir.
Thank you, Ketki. Thanks, Aditya. And Shruti for that wonderful session that we are going to have. Can I have this share? Is it getting shared?
Yes, it's shared.
Shared.
Yeah, we can see your screen.
So we are going to talk on the modern concepts in complex strabismus. And since this is more and more focused on pediatrics, we are now realizing that we are moving on from just cosmesis, personality, diplopia to binocular vision and stereopsis. So that's the first change that I would like to stress upon, that we are not just treating strabismus, but restoring binocular vision and stereopsis, because we are going to be tackling early and having full alignment as far as possible, as introduced by this nice case history of Dr. Kenneth Wright's son, that if you deal in time then and do it properly, you can restore stereopsis to the fullest amount. So the times are very important: 6 weeks, 6 months, and 6 years. As for congenital cataract, we have 6 weeks. For esotropias, we should be seeing in 6 months and tackling by the first year. And for the other conditions also, make sure that anything which is constant is treated by first year. And if it is intermittent, you can wait till about 5-6 years. The instruments are simple. The most complex instrument is the one which is God given to all of us. Some things about incisions. The incisions have been some which are standard. The recent one, which is MISS, or the minimally invasive strabismus incision by Gobin, somehow is not so advantageous, and we stick to the fornix incision mostly. And for the more complex ones, resurgeries, we do the limbal incision. The procedures that we are usually having, of course, is the recession, the conventional one. But whenever you have a complex case, you can do a adjustable recession to take care of it. And it may be a 2-stage adjustment. That means after 5 or 6 hours or after 24 hours. Or it may be a sequential GA. If you are having the luxury of GA time, you can do a GA, break in between, and then again have it. Or you can have a single stage adjustable surgery under the in the operation theater itself. Coming to the procedure of adjustable, the schematically as it is being shown, it may be better to have a hemi hangback. That means you do not do a full hangback recession because it will cause collapsing of the muscle. A hemi hangback is always preferable. The choice is a 1.5 knot, or you can have a sliding noose technique. In the strengthening procedures, we are moving on from resection to plication, as it gives us the advantage of the preoperative, postoperative, as you can see, much cleaner surgeries. There is a resolution of lump in the initial first week, which clears up by usually 1 month. And for medial rectus, we have almost 90% of our cases, instead of resection, are plication. There is an early reversibility which is possible. You can easily undo the effect of the plication, which is not so with the resections, and you don't disturb the anti-segment ischemia, and there is no risk of slipping of the muscles. Coming to the DVDs, the dissociated vertical deviations, if we have a bilateral inferior oblique overaction along with the DVD, of course, the choice procedure is inferior oblique total anterior positioning. And this has an anti-elevation, which becomes a desirable thing for cases of dissociated vertical deviation. But what if there is no inferior oblique overaction? And what do you do for such cases which are having a DVD? So for that, we may have a choice of working on superior rectus recessions with Fardens or whatever, or we may have the other procedures like inferior rectus plication. Now, we had done a study and we presented in APOS this year, comparing these cases of DVD without inferior oblique overaction, superior rectus recession with a Y split. Now, this is a little newer concept that we are splitting the superior rectus, and this gives us a Farden-like effect. So if you see these cases of DVDs, you know that the eye slips. So here we may not go into the details of the surgery because of the lack of time. But remember, we are going to split the superior rectus in the same way as the lateral rectus is being split for Duane's retraction syndrome. And we are separating the two ends of the superior rectus in Y split by 22 millimeters. Now, this gives us an effect of Farden. This is shown by a nice article which is published in in Journal of Ophthalmology, that a Y split gives you an effect like a Farden. And this is something which becomes very effective and useful for superior rectus, where you do not want to have a Farden procedure which is having more complicated surgery. So this is the pre-op and post-op of the case in which the Y split has been done. It gives us very desirable effects. But the more recent thing that we have moved on for is the inferior rectus plication. And this case, which has a 10 prism diopters of DVD PVC undercover test. And after the plication, as you can see, it is very effective. Now, this I'll just show you a small video of the inferior rectus plication. You may have seen for the medial rectus, it's almost similar to what you do for the medial rectus. The inferior rectus is being hooked, exposing the IR. On either side, the temporal septum and nasal septum is dissected. Here, important that we are dealing with IR, we need to separate from the check ligament so that we do not have the shifting of the lid up or down. And we are going to pass two sutures on either side at the desired point, usually about 4.5 or 5 millimeters of application we choose to do mostly. And here it's like passing in the muscle, back into the sclera, and then back again into the muscle. So it's a MSM, a muscle, sclera, and muscle bite, like a figure of 8. So these bites have been taken, then an iris repository is placed as a fulcrum, and as we tighten the sutures, it folds very nicely, and the muscle can be tightened, and the sutures can be trimmed. So this gives us a very desirable anti-elevation effect for correcting the DVD, with the advantage that we are not disturbing the anterior segment blood supply. There is a mini plication also, which has been proposed by Kenneth Wright. And again, we find it very useful for cases in which there is a small angle deviation, vertical, which is about, let's say, 5 to 8 or 10 prisms, like this girl has in the left eye, pre-op and post-op after this surgery. In this, a central bite is taken. Rather than 2 bites, we are just going to have a central bite and then bring it forwards and correct it. Now, divergence, excess, exo, if there is near distance disparity, what do? We can do a combo or Scott procedure on the lateral rectus, just like a Farden on the medial rectus. It works very well for lateral rectus, and the combo procedures are something which we do, resection and recession on the same lateral rectus. Again, because of lack of time, I think we may not have the details of the surgery, but remember, it's very simple. You mark on the muscle the amount to be resected, and then the recession amount will be decided. If you do not want any primary position change, then you may do the X is equal to Y. The amount of resection is equal to the same as the recession. If you want some change in the primary position, you add that. So Y will become twice the amount of X if you want the effect for both. So this is very good for lateral incompetence cases also, a combo resect Scott procedure. For the inferior obliques, we may have different types of situations which we have to cater to. Inferior oblique overactions may be there, in some cases more in one eye than the other. So you have to do different corrections for different cases. The sizing is very important. So do we have an option? Yes. For the inferior oblique, we may do a Fink, Sparks, Elite Nankin, or even a modified Elite Nankin, and of course a newer one, the anterior nasal transpositioning. Now this is pure recession, which is correcting both the elevation also as well as torsion, extorsion. If there is DVD, as we talked about, the choice procedure would be a total anterior positioning like this. But if there is a severe inferior oblique overaction, we choose to do an anterior nasal transposition, in which the inferior oblique is going to be positioned on the nasal side of the inferior rectus. 2 millimeters posterior and 2 millimeters more nasal is the ideal position, which gives us no anti-elevation. But if you want an anti-elevation, you can move it more anterior. So this is the procedure of anterior nasal transposition for the inferior obliques. Now, superior obliques, what are the procedures at our usual disposal? We avoid the procedures which are free tenotomies or tenectomies. A PTSO is a good procedure for mild to moderate superior oblique overactions, but for more severe ones, we may do a hang-back recession nowadays, and instead of silicone expander or translational recession. This is the PTSO. Again, I think we do not have the luxury of time, so we cannot go into the details of video. But these are very good procedures because they are controlled procedures for controlling both the superior oblique. And for the transposition procedures, now we have the different options. The partial tendon VRT, a full tendon VRT, a single muscle SRT or IRT. And we also now have the Nishida's procedure. Now here we are showing schematically a vertical rectus, partial vertical rectus transposition with cross-acting passing of the sutures. This gives us added vectorization of the force without the Foster's modification, and it also allows us to adjust. So this is a nice procedure. Similarly, the modified Nishida procedure is also very useful because there is no risk of anti-segment ischemia, and directly you can transfer the force. So I would just move fast to tell you that these cases are having the advantage of vessel sparing. In the myopic cases, we nowadays do the loop myopexy. That means superior rectus and the lateral rectus are stitched together with athi-bound suture in the superior temporal quadrant. And we may not have the time for more detailed thing, but nasal transposition of split LR is another new procedure which has come to our disposal for correcting third nerve palsies, which are not very tight lateral rectus. So finally, we may say that, yes, we have lots of options for targeted strabismus surgery. There is lot more still there, but we may have, and then of course, nystagmus will be covered very nicely by Dr. Hertel. But our choice procedure for eccentric null procedure shifting is the augmented Anderson procedure. So be a squintellectual and take care of your cases. Thank you for a pleasant listening. Thank you all.
Thank you, sir. It was a tough task and it was very fast but crisp and comprehensive. I have a small question. When you say that there is no inferior oblique overaction and there is DVD present, how do we choose between an inferior rectus plication and superior rectus Y-split? Like the amount of recession that you would do with the Y-split, how would we take the call?
Yeah, so both of these are equitable, working equally. And now we have switched more and more to the IR plication for the simple reason that this is a simpler procedure than the superior rectus recession with Y-split. And secondly, it is something which you can be easily undone. So as I generally say, use a razor with an eraser. So IR plication is the choice procedure for cases in which there is no inferior oblique overaction.
Thank you, sir.
Yeah.
Panelists, if they have to add something.
Yeah. So, sir, I have one question. Thank you again for wonderful. It was like music to our ears, and I know music is one of your passions. So it felt like a good melody to see your talk again. So I have one question for you, sir. So when I know that you are a big proponent of Nishida's modified Nishida's procedure. Is that your primary procedure for DRS cases, or do you kind of decide on what procedure to choose, or do you just go with the Nishida's?
Yeah, so the Nishidas or the belly transfer procedures nowadays, it's called without giving the name of the person. So these are advantageous procedures because you're not disturbing the blood supply. It's even better than SRT or IRT because you are not disturbing the blood supply of even a single vertical rectus. So that way it's a choice procedure. Even if you want a only let's say SRT has to be done or IRT has to be done, you can do a single belly transfer of either the superior rectus or inferior rectus. Again, that option is there. So we are moving more and more towards belly transfers than the transposition of the vertical rectus muscles themselves.
How do you feel the correction factor is, sir, when it comes to belly transfers versus a single belly transfer or a double belly transfer? Do you feel that you can titrate it based on the amount of action that we want, abduction that we want?
Yeah. So where you're stitching on the sclera makes a difference on how much effect of abduction you will get. So if you're going more and more closer towards the lateral rectus, you will get more effect of the vectorization of force. That is one thing. Secondly, if you are doing a balanced procedure, that means SR as well as IR belly transfer, it is safer, better without causing any vertical incompetence and any torsional effect. Right. But if you have a preoperative hypertropia, you may do an IR belly transfer, just like we were doing an IRT. And if you have a pre-operative hypotropia, then you may do a superior rectus belly transfer instead of SRT.
Yes. Okay. That's very interesting, sir. So then we'll be able to choose which muscle to do for the belly transfer in itself. So do we have any more questions?
I think we can take some questions with Dr. Hertel.
Yes, yes. So I now have the pleasure of introducing our second speaker, Dr. Jitendra Jetani. Dr. Jetani is an innovator and a stellar squint surgeon. He is what we call a hybrid surgeon. He's got a wonderful private practice as well as he continues to pursue academics and research in equal measure. He's the director at the Baroda Children's Eye Care and Squint Clinic. Like a serial killer, he's a serial winner at AIOS. He's got about 6 awards for best papers. He was awarded the Strabismologist of the Year by SPOCY and awarded the IRSI Gold Medal. And he's have several publications and is a section editor at the IJO in India. So, sir, welcome to this forum, and we are privileged to have your talk today. He's going to be talking on myopia.
Thank you so much. Thank you so much, Shruti, for a wonderful introduction. And thanks, Aditya, for the opportunity. And I will just share the screen. So I know today's World Sight Day, and a lot of talk on myopia is going on. Sharma sir was just live on news channel. I was listening to him. So myopic progression, what is the future of myopia progression? So I keep saying that, we are not treating myopia, we are treating myopic progression. We should always, whenever we discuss talk or, give talks about myopia, we should talk that we are actually talking about myopic progression and not really about myopia. So am I audible?
Yes, yes, sir, you are.
Yeah.
Yes.
Okay. So we will talk first about what is currently known. What are the risk factors for myopia? Now this has come up only in recent few years. In last 10 to 15 years, we have been able to know what exactly are the interventions. There have been many new innovations. Although there are a lot of things which were known previously, but they have been refurbished again. So a lot of debate, a lot of things started with this particular landmark article where Brand Vision Institute predicted that by the end of 2050 there would be almost 52% of people would be myopic, and but the criticism of this particular article is that this doesn't really have a lot of data from Indian subcontinent, and this is what was published from India in 2021 by Pawan and his group, where they also tried to see the time trends on prevalence of myopia in India. And India is not going to be far behind as far as the prevalence of myopia is concerned. And by the end of 2050, they predicted that the trends do show that it would be around 48% would be myopes. And these are based on the previous studies and extrapolation of the data. So the prevalence of myopia in 5 to 15-year-old urban children has increased from 4%, which is quite less, 4%, to 21.15% in 2019. So this is what they have extrapolated, considering the generation factors. The risk factors for myopia progression in school-going children. Now we have understood that they are typically low outdoor activities, more of near work, and especially a reduced reading distance. And why does myopia progress? Now, why does myopia progress? Mainly because of the near work. There is peripheral hyperopic defocus. Wonderful work has been done by Earl Smith on this, as how the peripheral hyperopic defocus actually, makes a difference in the progression of myopia, and how the newer lenses which are now available, they change this hyperopic defocus to myopic defocus. And then there is another theory that there is altered dopamine release, and atropine eye drops reinstate the dopamine release and thereby reduce the progression of myopia. Regarding atropine, we now know that it is concentration dependent. 0.01% is already available in the market. 0.02 is better. 0.05 is still better. You can use it daily, once or twice. We have started using twice daily, and I can see the future that we will have more stringent protocols as to which particular patient is going to progress and which particular patient is going to be benefited by low concentration atropine or with the glasses. And we have to consider this factor of rebound in low concentration atropine eye drops. Another intervention is peripheral defocus lenses. Now there are right now 3 players in the market: HALT, DIMS, and MyoVision Pro from Zeiss. Cost is one of the major prohibitors at this point of time. What it basically does is it creates a myopic defocus. As we can see, the peripheral hyperopic defocus is converted into myopic defocus, thereby reducing the urge to progress. So the eyeball is not trying to get ahead and try to increase the size. Now, some of the innovations that we did in our clinic for peripheral refraction, we made a small instrument. We do not have a peripheral for measuring peripheral reflection. We do not have an open field auto refractor. So this is what we did. We tried to use a device which was put on the retinoscope, and we tried to tell the patient to look at that particular point, and we can calculate the peripheral refraction. And another device which is already available, and we are trying to make a similar device. We are measuring the near work and ambient light. Dr. Shruti, they have already made a device which can measure the outdoor activities with the help of a UV tracker, which is there. It is just like a smart watch. The child can wear the smartwatch and can easily You can find out how much number of hours the child was outdoors. And another sensor which can be fitted in these kind of devices is time of flight distances, which can measure the distance between the device. You can see here we are trying to do the same thing. This is the scientist with whom we are working. And he's trying to see the things for near. And you can see that the live data is coming here. But the device is very cumbersome. The major challenge in this particular device is that, you know, how frequently you want to measure or how frequently you want to gather the data, because at the end of the day, you need a battery backup for that. And that is what is the challenge. And that is what where we would need the AI to build a better algorithm. And the future would be to design more tests to see who will be progressing, making more robust myopia calculators, which are more predictable, so that we can know that this particular, right now the challenge is that which particular patient is going to progress. So the problem is that we have to wait for at least 3 to 6 months before we can start a myopia treatment. So there could be some biomarkers which can improve predictability, which would help in selecting what treatment protocols we have to give to which particular patient who's going to progress. So thank you so much for the opportunity. I think it was a quick overview on the future of myopia progression.
Yes, it was indeed a very brief and comprehensive overview on myopia management. And I think nobody could have put it in such a clear and concise nutshell. So, I do know that you are a pioneer of low-dose atropine in India, and you have several studies to the credit. I know you have explored areas of research in not the regular indications. Like I know you have explored it in pseudophakia, yes, and also in pre-myopia. So I would like to know your experience in that, sir.
So, so we tried to use it in pseudophakics in children who are having once we have done the pediatric cataracts and they are still progressing beyond what we would consider as the physiological growth. So most of these children were above 4 years of age and they were still progressing, just like they were axial myopes and they were progressing axially. So we tried to use low concentration atropine, and we to our surprise, because we did not have any other tool to do anything. They were already pseudophakic and they were already using the so peripheral defocus, at least in one particular field, was not there. And so we started using atropine 0.01%, and then we started giving them reconstituted 0.05%, because these patients were not really bothered about accommodation. Right. So these patients, we could, there was a good control. And that is where we felt that, there was no role of accommodation or no role of lens, because the lens was already out. So that was regarding the pseudophakic children in whom we could get good correction. Good control in progression.
Yeah, so I think that goes to show that definitely atropine is not working at the level of accommodation, at least. So if it's able to bring about control even in pseudophakics.
Yes.
What about the pre-myopia, sir? What's your experience in that spectrum?
I think pre-myopia is a slightly longer. Pre-myopia, you have to select your patients very, very carefully. You have to see whether they are. So you have to be really into myopia. You have to calculate the axial length of all the patients who come to your clinic who are emetropes, or there is a history that other sibling is having myopia, or you see that you are seeing the patient having a very low hyperope. So normally a low hyperope, you would feel that there is no question of myopia. But we started calculating axial length for low hyperopes also, because we felt that these are the potential patients who may trip over, and only in those patients who are progressively going down the curve, who are actually showing axial elongation, at the same time, their hyperopia was actually reducing. So there are a lot of, we did almost 200 to 250 patients and could get only some 25 to 30 patients. So there are a lot of patients who really don't go the myopic path. They remain emetrope. So my point is that we have to understand that there should be a progression, as we were discussing in POS, and also that there should be a progression to treat the progression, because so you have to take axial length in all the visits, and you have to do a cycloplegic refraction, which we obviously do in all the patients, but you have to calculate the axial length also to actually document that these are pre-myopes. So the pre-myopes are basically children who may be very low myope or who may be emmetropic, and there is a axial length change which you have noticed over a period of couple of years.
Yes, sir. So additionally, also children who have parental myopia, I mean, whose parents have myopia are inherently need to be monitored a little more carefully for the.
Very true. Very true.
Yeah, thank you, sir, for your inputs. Any comments from the other speakers here? Yes, Dr. Sharda, please.
Yeah, so thank you, Dr. Sharma and Dr. Titani for the wonderful talks. Just trying to make a point of again about the pre-myopia. Unfortunately, for our Indian children, we do not have the data of what is a natural change in the axial length. So how do we take a cutoff like this is a natural growth and this is something that will go into myopia is something that collectively all of us have to work on and find data for our own population. Only then we can, really take that decision whether this child needs treatment or just observation. So that is just what I wanted to add.
Yes. So another way is to also look for progression in the hyperopia, like the reduction in the hyperopia.
Yeah, even that. I mean, a 0.2 millimeter in a year, a growth in a 6-year-old child may be normal as compared to a 14-year-old. And what is that normal in our Indian population is unfortunately not known.
Not studied. Yes, absolutely. Yes. Dr. Ketki, can you introduce the speaker?
The next, I would like to introduce the next speaker, Dr. Vaishali Vasavda. She's a pediatric glaucoma and cataract surgeon at the Raghudeep Eye Hospital. She has won awards at the ASCRS and has many publications in peer-reviewed journals. I welcome her to give her the talk.
Thank you so much. Thank you, Dr. Ketki, and thank you, Aditya, and everybody for this wonderful opportunity, and most importantly, to listen to all the stalwarts talking. I think that's one of the main perks I'm looking at today. So I'll be very short and brief. I must say that I'm a cataract surgeon primarily, but I do a lot of pediatric cataracts. Now, what is new, or what is it that I think I'm doing differently in the last few years? I think I want to just touch upon two aspects in this limited time. Number one, even today, we believe that for children below 5 or 6 years of age, performing an anterior vitrectomy is an integral part of the surgical plan because we want to avoid visual axis obscuration. We know that the anterior hyaloid acts as a scaffold on which the cells are going to proliferate and give a bad PCO or a visual axis obscuration. But we also understand that these are the very eyes which are prone to more complications. They may be predisposed to glaucomas, for example. And what if we could avoid an anterior vitrectomy? Is there some way we can avoid an additional procedure? So here in this video, I'm just showing a classical Acrisof IOL hydrophobic, no financial interest, is placed in the capsular bag. And then I'm going through the pars plana route about 2 millimeter behind the limbus and using my vitrector to perform a posterior capsulotomy along with vitrectomy. So vitrectomy is often done after IOL implantation, but it can be done before also. It can be done through the limbal route or the pars plana route. That I think is a matter of choice, but whichever way we do it, we are disturbing the vitreous. So I think it has 2-3 implications which we really don't know. Like Shruti said, there is so much we don't know in literature. Number one is what effect it will have on the vitreous base and retinal complications. Number two, whether changing the concentration of the ascorbate free radicals from the posterior and anterior vitreous by performing that anterior vitrectomy is going to change the incidence of glaucoma. And number three, is it going to affect the axial growth, whether you perform a vitrectomy or you don't? So what if we can avoid any additional procedure, but particularly vitrectomy, and yet do away with the most feared complication or sequel, rather, not even a complication of pediatric cataract, which is visual axis obscuration. So that's where the technique of optic capture I'm going to talk about. I must say that this is not a new technique. This was first described by Dr. Thomas Nohan for an adult eye with traumatic cataract many years ago. And then Dr. Howard Gimbel from Canada was actually the one who brought it into pediatric practice. And this was the time when single piece PMMA IOLs, and in his study, the Pharmacia IOLs were being used. So like I said, the credit really goes to Dr. Gimbal for popularizing this technique in pediatric eyes. So I just want to show how we perform this. Now, what we are going to do, this is a near mature pediatric cataract, and anterior capsular excise is performed. Bimanual irrigation aspiration is performed to remove the lens matter. And then, as you can see here, there is an anterior capsular excise and a manual posterior capsular excise also has been performed. It is crucial that the size of the posterior capsular excise is somewhere between 4 to 5 millimeters, not more than that. Because now what we are going to show is a posterior optic capture. What happens here is that a 3-piece foldable lens is placed between the anterior and posterior capsules. That means it is put in the bag. The haptics and the optic both go inside the capsular bag. Now, once that is done, you take a dialer or a Lester hook or a manipulator and gently slide the edges of the optic behind the posterior capsular excise margin. So note here that until now, no anterior vitrectomy has been performed. And the sign of a successful optic capture is this dumbbell sign or an overlaying of the posterior capsular excise margin. So what this actually does is the entire optic gets pushed down below the posterior capsular excise and the haptics still remain in the capsular bag. As a result, the leaflets of the anterior and posterior capsules will fuse in the periphery, except for this small area of the optic haptic junction, and thereby giving two things. The lens epithelial cells, which obviously are coming from the equator, will not be able to cross this fused margin, and therefore the center of the eye will remain clear, even though the vitreous is intact. So you avoid a vitrectomy. But what is also, I think, we find very useful is the fact that it also locks the IOL in by sort of sandwiching the IOL and therefore avoiding its movement. Here is a follow-up picture taken under EUA of a 3-month follow-up. And this is an animation to show what actually happens during optic capture. As you saw, the optic is behind the posterior capsular excise. This is just a schematic to show that once the optic is captured, then it's not going to move in the anterior, posterior, or lateral directions. So you have two benefits. One, you are locking in the lens epithelial cells and therefore have a clearer visual axis. But I think what is also very important is that there is going to, the chances of an optic capture or movement of the IOL are completely, decentration are eliminated. And we published way back, several years back, we published 1-year outcomes. Basically, we did a randomized clinical study in children between 6 months to 4 years of age who are undergoing congenital cataract surgery, and one group randomly received in the bag IOL of the same 3-piece Acrysof IOL with an anterior vitrectomy. The other group where 3-piece Acrysof was placed in the bag and a posterior optic capture was performed without a vitrectomy. To briefly show you what we want to show is now we have data up to 3 years of this, and the rate of visual axis obscuration is extremely low in both groups. But in the optic capture, until 3 years, we have still not seen any visual axis obscuration. And it's very good to say for children about 2 years, 3 years, because anyway, they get less obscuration with the modern techniques and lenses. So when we looked at children below 1 year of age, which were about 45% of the entire cohort, again, none of them in the optic capture group at 36 months follow-up has needed any procedure for a visual axis obscuration. And inflammation as well as glaucoma were also comparable. So I think what I want to say is that this is a very good technique to consider. Start with older children. It's very, very difficult to perform in children below the age of 6 months or maybe even 1 year for relatively less experienced surgeon. But I think any child above the age of 18 months, one should try and get used to and then come to lower age groups. The other last thing I wanted to talk about was the use of femtosecond laser. I know this is a white elephant, and to get it and more importantly, do it in a pediatric eye is very, very challenging and sort of next to impossible because of the fact that you need 2 devices. Currently, all the laser systems need a docking device. And for that, you will need 2 separate sterile devices. One for the anterior capsular axis, second for the posterior capsular axis. But wherever you can, I think I just wanted to show some beautiful snapshots. And this is the anterior axis. without the eye being opened. Yet we have not yet entered the anterior chamber, and you can see this retracted capsule. And this is the posterior capsular axis. So it is possible to perform under GA. It is extremely challenging. But what I wanted to highlight here is that the margins of these capsulotomies, of laser capsulotomies, are, there is a lot of, there was in the initial period criticism regarding the strength of these rexes or capsulotomy margins. But you can see that we are performing a posterior optic capture through a femto PCCC. So that means you can perform wherever you do have the opportunity or access, and there's nothing wrong. Yes, cost is the biggest factor, but that often is not the only consideration. So I think this is what I wanted to highlight, the few things. And thank you so much for the time and the opportunity.
Thank you. A fabulous presentation of the new technique. Very intriguing. I have a question though. When we do the optic capture, there is low possibility or absolutely no possibility of having the visual axis opacification because of the lens epithelial cells migrating in front of the IOL after like many years. Is there cases where they have been reported?
So from our experience, we now have children who have completed more than 5 years of follow-up, and we don't see anterior migration because these margins fuse across. The only place where the margins are open is the optic haptic junction, but that's why the 3-piece IOL, not the single piece, which those square haptics is not there. So we don't see anterior, what we do see is a phimose. When those capsules are fused, they do tend to phimose a little bit. But except for 1 or 2 cases over these 5 years, we have never had to do a membranectomy anterior. So it's not that bad. Within the pupil, they still have a very clear visual axis and they have not needed.
Sometimes even the in the bag IOLs also have that.
I think I must say that now with more modern techniques and these IOLs, we are seeing much less of PC or VA than what we used to. But that still means you would have to do an anterior vitrectomy when you are not doing a capture. So we are avoiding a vitrectomy and still being able to get at least as good outcomes. So I think that is the thing that works for me.
Yeah, very, very good results. And it also saves a lot of time.
Yeah. One quick question. You spoke about femto. Now, femto, there's been a very nice article by Dr. Dick, which you quote. He used a femto docking machine in the same OR.
Right.
He was docking on one side and he was doing the cataract on the other. And that seemed like a good option, but is that practical? Does that?
So yeah, I mean, that is a brilliant thing if you can do it. I mean, he's lucky to be in a facility where the OT is large enough where he can house both. So yeah, if you have in the theater, then so the biggest challenge that in whatever select cases we do is shifting the patient from the OT to the laser under GA. So we need a team of 3 anesthetists and it's a very high risk thing to do. But yeah, so if you have access, and now we have newer lasers. The Zepto somehow didn't pick up as much as we thought it would. We have a new laser, capsule laser, which has come in the market, which is a sort of a portable device. And if that proves helpful, I think that will be the best thing for pediatric eyes. Then you don't need a femto also. And it's much, much cheaper than a femto.
And what about multifocals? Because that even works, in my head, it even works for progression post like multifocal lenses. Contact lenses work very well for myopic progression. So why not multifocals also for pediatric advancement?
I think, I mean, most of us sitting here, I think our major reservation is the change in the quality of vision, because the current generation, they all split the light. So there is a reduction. Plus, because of the diffractive optics that most of them have, there is a drop in the quality of vision. So therefore, but yeah, there is a role, I think, with EDOF lenses and very rarely with multifocal in older children, 13, 14 and above, unilateral particularly, or syndromic where they cannot handle any kind of refractive correction. So in older children, 13 and above, yes, it shouldn't be ruled out.
Okay. Thank you, ma'am.
Thank you.
We have some pediatric ophthalmologists actually adopting EDOF lenses for slightly older kids, and they do report good outcomes with it. So that's
we have a study of about 15 eyes, which you compare to monofocals.
Yeah.
will be coming out hopefully.
Great. We look forward to that. Any comments from Dr. Jethani, Dr. Sharma, or Dr. Shailja? Would you like to add?
No comments. Excellent talk, Dr. Vishali. I also try to shift to optical capture. The only struggle that I have is that this multifocal Acrysoft lenses, they kind of open sometimes very violently in the AC. And then it disturbs the anterior vitreous, and you end up doing an anterior vitrectomy, which you wanted to avoid in the first place. So how do you really avoid that? And do you use a special injector or any special technique?
So yeah, that's a great thing. I think my two struggles, you have only one struggle, I have two struggles. One is to get a posterior capsular axis of the right size and centration.
Yeah, that's also one.
And then the main thing is to use a 3-piece foldable lens.
Yeah, this 3-piece only, I mean the multi-piece.
Yeah,
it just unfolds sometimes very
correct. So what I do normally is I use I enlarge the incision. Normally 3.2 is the recommended size for the B cartridge that this goes through, but I would enlarge it to about 3.4. I don't want a tight incision. When you force, then that happens. And typically we use a Lester hook to guide the leading haptic. Once the leading haptic goes in the bag, then you can use either a McPherson forceps or even dial it in. But you are right, it's not like it will never rupture you can cause a vitreous damage iatrogenically. So it is mandatory to use triamcinolone after doing the capture to make sure that there is no vitreous. If there is, then there is no ego and we have to perform an anterior vitrectomy. So yeah, I think my key is to go very slow. In fact, in the initial phases, I used to do a manual holder folder technique.
Yeah.
That I'd never used an injector. I would make a 3.6 mm incision and use a holder folder. But now, since I'm more comfortable, I just guide the leading haptic very gently, but I use a larger incision. I don't want any tight or a pressurized, like you said, opening up.
We do have preloaded ones now available by Orolab. They also work pretty well.
Yeah, I think now there are good, lots of good brands available.
Great. Thank you, ma'am.
Thank you.
Thank you.
Dr. Hertel is supposed to join us at 8 o'clock, but I think he's still stuck in his OR. So in between, whenever he joins us, I'll ask us to accommodate. So we can have Dr. Shailja, ma'am.
I would like to welcome Dr. Shailja Tibrewal, my good friend and a avid researcher working at Shroff as a senior consultant at Shroff Charity Eye Hospital, Delhi. And welcome, and over to you, Dr. Shailja.
And Dr. Varda is also here. She'll be asking you questions.
Yeah, thank you. I'll try to share my screen.
Is there any difficulty?
No, just not able to. Yeah, can you see now?
I think we should be seeing it soon. Yes, yes.
Yeah, thank you. Thank you, Aditya. Thank you, Ketki, for that wonderful introduction. Thank you, Shruti. And I will try to do justice to the topic. It is role of genetics in pediatric eye disorders. And I have the first disclaimer that I'm not a geneticist. So this is something which I'm trying to develop, and because it intrigued me during my initial years as a pediatric ophthalmologist. Now, in most of the pediatric eye disorders that we see in the clinic have a direct or indirect relation to genetics in almost as high as 50% of them. And the conditions that cause legal blindness in children, genetic eye disorder, constitute more than 50% of them. And overall, because they have no cure, they have huge economic and social impact. So more than this, what intrigued me was that the helpless situation that I faced when I dealt with a child with a genetic disorder, that what to do next, do I have something to offer to them? So that is how my interest developed. And if I look at the entire eye, all aspects and all components of the eye, the genetic disorders do affect them. And if you just eyeball all these conditions, you would see that you would see most of them in day-to-day practice. So apart from just the eye, they're also associated with systemic disorders. So that also is an important aspect. And we, as most of us are trained mostly in isolated eye hospitals, and so the exposure to systemic disorders and systemic conditions and different, colleagues in different branches is less. So when you actually see them practically in a clinic, you are, lost and you don't know what to do next. So I'll take through some of the examples of cases where a genetic diagnosis or any concept of genetics helped. This first case is a 26-year-old male who came with a history of sudden onset blindness, gradual progressive, simultaneous bilateral loss of vision. Okay, so the onset was at 18 years of age. And as you can see, that was simultaneous. Both eyes were affected together. And old records documented bilateral optic neuritis as a diagnosis. At that time, he received IVMP, and the MRI was normal. And current vision is 1/16 both the eyes, and the fundus showed a bilateral optic atrophy. So what is atypical here? If you think about it, male patient with optic neuritis, bilateral one, there was absence of pain. There was a slow progression after that. If you when I asked him that, even after the bilateral loss of vision, the slowly kind of progress, which is not the usual thing with bilateral optic neuritis, but we also know that there could be atypical optic neuritis. But then what we did is, thinking that are we missing something, we just dwelled into the family history a little bit, and he said that two of his cousins from the maternal side also had some vision problem, and where the visual recovery was very poor. And we asked him for the records, and lo and behold, we found that they were also diagnosed with optic atrophy. So 3 members affected, all diagnosed as bilateral optic neuritis at a young age, all were males, and all share the maternal lineage. So now there is a pattern, and we think about hereditary optic atrophy, and first thing that comes to our mind is LH1, very rarely X-linked optic atrophy, but LH1 would be on the top of my list because of the sheer prevalence that is more common. So mitochondrial inheritance typically will affect both males and females. However, LH1, due to some unknown reasons, is more common in males. Also, typical mitochondrial pedigree, like the pedigree shown on the top, would include ideally all the children of the affected female should be affected, and no child of an affected male should be affected. But in practicality, the mother does not transmit it to all the children because of a concept called as mitochondrial heteroplasmy. So I've just shown this slide because interpreting a pedigree might be difficult in a simple disorder like LH1 also, and it needs a little bit more in-depth knowledge about pedigree analysis. So we went ahead with genetic report, and it confirmed the pathogenic mutation for LH1. Not going to details. So what is important to make a diagnosis of genetic disorder? One is prognostication. Now in optic neuritis, a recovery is often seen. Also, there is a risk of repeated attacks. But in hereditary optic atrophy, generally could be progressive. Course might be different with different mutations, and there is a genotype-phenotype correlation which is known. So this is how you can actually counsel the patient. You can tell them exactly what is happening to them and what they expect in future. The management of optic neuritis is totally different as compared to hereditary optic atrophy. Had he been diagnosed with an LH1 before, he could have been given the benefit of idebenone or coenzyme Q. He could have been asked to refrain from smoking or alcohol, etc. But this was a misdiagnosis. And of course, genetic counseling, he himself is not will not be transferring it to his offsprings, but if he has a sister who is affected, or is a carrier, maybe a carrier because of mitochondrial heteroplasmy, may transmit it to her children. The genotype-phenotype correlation can also be seen in LCA, and just take an example that LCA or EOSOD, which is early onset severe retinal dystrophies, they have almost like 70 genes which are known to be associated with them. And based on the mutation, there could be different spectrum where it can be presenting as a predominantly cone dystrophy, predominantly rod-based dystrophies, could be the typical LCA where, the retina may be normal, retina may be abnormal. There could be like severe early vision loss. There could be progressive. So how do you just prognosticate, and how do you counsel the parents at what to expect in that child in future? So again, genetic diagnosis helps here to really prognosticate them and tell them what to expect. Another application of genetic diagnosis, like this is very commonly encountered disorder, aniridia. So aniridia could be familial in 2/3 of the cases where it is autosomal dominant associated with the PAX6 mutation, and sporadic in 1/3 where it is associated with deletions of the 11p13 chromosome. And when it is associated with deletions in a sporadic case, along with the PAX6, you could have a WT1, which is a Wilms tumor gene, also being deleted. And if it's deleted, then around 50% of those who have a WT1 deletion or mutation can have Wilms tumor, which is a very aggressive childhood tumor, and if missed can lead to death. So in this child, what do you do next? Again, you have to take a pedigree. So if there is a family history, you see an obvious aniridia in the family, the Wilms tumor can be, practically be ruled out. In most of the case, it won't be there, yet it might be missed in very, very small, minuscule of patients. So you could go ahead with the genetic diagnosis. And if you see the Wilms tumor gene being affected, then you can actually screen for the children by systemic examination, which are recommended as shown here. So family history and examination of parents, extremely important in all aspects of pediatric eye diseases. It can even clinch a diagnosis. Sometimes parents are carriers, and these carriers may have specific phenotypes which can lead to instant diagnosis. Some of the examples are the tapetoretinal sheen in female carriers of X-linked RP, a posterior Y suture cataracts in Nance-Horan syndrome, which is associated with X-linked congenital cataracts, microcornea, microphthalmos, this very typical screwdriver teeth, and dysmorphisms. The anterior fleck-like sutures in cerebrotendinous xanthomatosis, which is again a very crippling disease if not identified early, associated with infantile onset diarrhea, juvenile cataracts, and tendon xanthomas with progressive neurological dysfunction. It has a very basic treatment available for us to make a cause for an early diagnosis. So this case is a 6-year-old male, firstborn, a first visit in July 2019 with complaint of distant vision. He had a compound myopic astigmatism, very mild subluxation of the lens as shown. So whenever we think of subluxation, this is very, one of the often diagnosed genetic disorder, I would say, and most likely not missed. But in this patient, we did not have any wrist sign, any thumb sign, any pes planus, any scoliosis, kyphosis, chest deformity, no high arched palate. Only thing was a mildly increased arm to span ratio. Now here, do you think, okay, is it a Marfan's? Is it not a Marfan's? So another only one thing which was a little bit hinting towards it was presence of a flatter cave. We examined the parents. Now, the mother also has a history of subluxation. She was a little bit tall and lean for age, but yet again, there is a dilemma whether it's a simple ectopia lentis or Marfan syndrome. So what more to do in them? So for Marfan syndrome, at least you have a non-genetic test which is available. You just order a 2D echo, refer to a cardiologist. And here we did find that he was fitting into the Marfan syndrome category using the Ghent 2 nosology. But the parents also wanted to know the recurrence risk and finally confirm it. So we went ahead with genetic testing, which confirmed this FBN1 mutation. So some of the syndromes, very commonly ones are the Down syndrome associated with cataract, brush with spots, poor accommodation, even keratoconus and CNLDOs. Some of them which are not so common but may have further, more serine complications or implications is this Hallerman-Streiff-Feinkohl syndrome, which can be associated with bilateral congenital cataracts and microphthalmia. More than microphthalmos, behaves like a nanophthalmos, and they have very difficult intubation. So you have to warn your anesthetist that it could be a difficult case. Similarly, Rubenstein-Taibi syndrome, which is associated with colobomas, glaucomas, can have, succinylcholine sensitivity, and anesthesia may be dangerous. So a knowledge of this would help your anesthetist to plan the case properly. And so I would say that any child, how do you identify these syndromes? We are not experts in it. Nobody can be. There's so many syndromes, but identify these red flags like intellectual disabilities, any congenital anomaly, dysmorphic features, presence of immunodeficiency in the form of frequent infections, history of recurrent pregnancy loss in the mother, anything odd. If the child looks odd or appears odd as compared to the parents or the other family members, you might be dealing with a syndromic child here. So this is one of the last slides. People often ask when and why to order a genetic testing. They're so expensive. What do they offer to us? So you have to have a genetic diagnosis. I was shown by so many other examples. It may not be required in all cases if the clinical diagnosis is conclusive. In some cases, you have a very typical genotype-phenotype correlation, and so genetic test may help you to prognosticate the patient. You may be able to estimate the risk to the siblings or the offsprings. For preconceptional and prenatal testing, it definitely plays a role in parents or on people who are interested in knowing what would happen next. Like in this patient, this 2-year-old child had an LCA. So the mother had a missed abortion and she was 13 weeks pregnant. So she wanted to know the recurrence risk in this child. So we went ahead and found this mutation in this proband, and she went ahead for prenatal testing, and a similar mutation was found in the current pregnancy. And then the decision of getting an MTP is left on to the parents if they want. Some of these treatment options are available in very few disorders, I would say. Largely, we do not have much, much of these treatment modalities, but more and more are coming up. So we should know that treatment options may not always mean very expensive gene therapy. Sometimes replacement of a defective protein like in cerebrotendinous xanthomatosis, change in a substrate, or prevention of accumulation of harmful products like coenzyme Q in LHON. Stem cell-based therapies are also coming up, or using the modification of process of genetic defects like atelurine for aniridia. So lots and lots of these are being explored in the area of genetic disorders, and we should have some inclination and knowledge to be able to offer them to our parents, to our patients eventually. So genetic counseling, I would say, is the cornerstone for treating these patients. The first step that you need to do is actually give them a good option of a genetic counseling, linking the patients to various support groups, because most of them do not have any cure. And whatever we can offer from our side is at least give them visual rehabilitation and cosmetic rehabilitation if possible. And thank you. I would like to thank Ria, who is a genetic counselor at SCH and supports me in all management of all these patients, all my patients and my mentors. Thank you.
Thank you, Dr. Shelja. It was a very clinically oriented talk, and it was very important that this talk was taken here. I want to ask you if I do find a patient that needs and wants a genetic counseling, how do I process it from a different city from where it is available to another city? Is that like how do we get the logistics done of the genetic testing part?
Okay, so nowadays, most of these genetic tests are available in most cities, even in 2-tier, 3-tier cities. These labs, they have their collection centers, and they can collect sample from almost everywhere if you pay them, frankly speaking. So genetic testing is not an issue. Even some of these labs, they also offer genetic counseling over phone or over a WhatsApp call. They can counsel, they have counselors with them, and they can counsel. Or you can always send to us, Ria, or ask Ria to counsel. She will.
All right, thank you. And what about the fact that, if what type of treatments are available at the moment in India where we can say, okay, this is kind of treatable for Indian population?
So currently, if you talk about gene therapy, gene therapy is not really freely available in India. Only for RP65, the Luxturna treatment has come, which is very expensive. But I know that, Narayan Netralaya, Dr. Arka Ghosh is doing something regarding this, but not heard from him regarding any progress so far, and something which is out there for everybody.
All right. Thank you, Dr. Shruti.
The rest of the supportive treatment is there, as I mentioned.
Yeah, definitely.
Professor Pradeep Sharma, sir, Dr. Jethani, would you, or Dr. Varda, would you like to add your comments? Any questions? Okay.
Great talk, ma'am. Dr. Hurtle is going to join us in a minute or so. He's between OT. So yeah, he's just joined us. So I'll, in about a minute, sir's here. Hi, sir.
Hi.
Great to have you.
Hello.
Sorry to pull you out of the OT.
That's all right. I'm in between cases. You know how it goes.
So I'll get Dr. Shruti to introduce you, and then we'll have your talk.
Okay.
Yeah, welcome, Dr. Hurtle, and it's an honor to have you here. Dr. Richard Hurtle is a world-renowned pediatric ophthalmologist and an nystagmus specialist with years of research in nystagmus. He's the director of Akron's Children Vision Eye Center in Ohio. He has taught ophthalmology for a decade almost before and has worked in Maryland and Washington as well. He's closely associated with India, where he travels almost every year to help in the management of complex nystagmus procedures. I have his book in my library, and it is one of the books that I feel I constantly pull out to before I do any procedure. And believe me, he sums it up so simple that only a true master of the topic can actually make it so simple and effortless. So it's a great honor to have you here, Professor Hurtle, and over to you to give your talk, your keynote lecture.
Thank you. Thank you very much for that excellent introduction. Good. I think I'm screen sharing now.
Yeah, we can see your screen, sir.
Okay, tell me if you see my PowerPoint. Do you see my PowerPoint?
See your PowerPoint, sir.
Good.
See the slideshow.
Good. All right, so I'm going to spend only about 15 minutes. I was told that 12 to 15 minutes to try and talk about nystagmus. So I want to summarize a few of the basic concepts that I think are issues in the field of nystagmus. And then the details of this, as was mentioned, is both in the literature and in the textbook, which is free and can be downloaded online. So I'd like to spend some time talking about some crucial topics. The first is classification and naming. I think that there's a lot of confusion about the classification and the type and name of nystagmus. And this is a list of nystagmus diagnoses. As you can see here, these are mostly eponyms, the names of people, and some clinical description of what the eyes do. This is also very confusing, but this was taken out of a textbook, and it's not uniformly accepted. There's no uniformly accepted classification system of nystagmus. And so what we tried to do is come together and build one. The other problem is that not all eye movements, abnormal eye movements, are nystagmus. In order for an involuntary oscillation to be classified as nystagmus, it has to have a slow phase. Nystagmus is designated and diagnosed by its slow phase. There are a number of types of eye oscillations that look like nystagmus, but are actually fast phase oscillations. And this includes the child that you see up here on your right, who has ocular flutter. And these are 14 types of eye movement abnormalities that are considered saccadic abnormalities and have a completely different neurophysiology than nystagmus. The only true way to distinguish among and between these is the use of eye movement recordings. Just to give you the story on the naming of the most common type of nystagmus that usually begins in infancy, somewhere between 1 and 4 months of age, which we now call infantile nystagmus, is still called around the world either sensory or motor or congenital sensory or motor nystagmus. And the true story of this begins with Dr. David Kogan, who in the late 60s tried to help clinicians understand nystagmus, and he found that children who could see and children who couldn't see both had nystagmus. So he classified those into sensory and motor. Those that couldn't see and had nystagmus was sensory, and those that could see and had nystagmus were motor. He also classified them as congenital. This was in 1968. In 1974, he attended a conference and he heard a paper by Bob Daroff and Lou Deloso where eye movement recordings were accomplished on both these population of children, showing that the actual nystagmus was exactly the same, whether or not the children could see or not see. So he wrote this letter to Bob Daroff in 1974 saying that the classification of nystagmus in childhood into sensory and motor should be abolished. So the same person that initiated the classification sought to abolish it, but even his word was ignored, and it persists even to this day. And this is the kind of
false persistence that occurs in all areas of medicine. So this is not a sensorimotor nystagmus. They have the same type of nystagmus, and it's not congenital. It begins at 1 to 4 months of age. What we tried to do when I was at NIH was bring together a multidisciplinary group of personnel, and these include scientists, clinicians, optometrists, and also biologists to understand all eye movement abnormalities and strabismus and come up with a classification system that clinical scientists could use to begin their research. And this is CMAS, and you can get this at the NEI website. And the CMAS classification of eye movement abnormalities and strabismus has a fundamental group the same. It's an 85-page document that even classifies all the forms of strabismus as well. And the CMAS nystagmus types you see here are the 11 that you see here, and the 3 most common you see in infancy are 9, 10, and 11. This is infantile nystagmus syndrome, fusion maldevelopment, which used to be called latent or manifest latent nystagmus, and spasmus nutans. And these are differentiated clinically and electrophysiologically with eye movement recordings. And so it's important to use that technology to try and understand these diseases. One of the things I try and get across to anybody who deals with patients with nystagmus, including the family members of patients themselves, is that any child with nystagmus has a unique visual system, a visual system that needs to be comprehended in the following way. You and I see the world statically. The world looks the same all the time, regardless of what happens to me or regardless of what happens to the world, unless something pathologic or a medication, some aberrant event takes place. The world always looks the same. I can sit and look at the coat rack across from me for 2 hours and it will never change. Patients with nystagmus have a period of time where their nystagmus, their visual functions, all of them, no matter what you measure, and you see examples of this here, change. They have a period of time where they have their best visual function, say contrast sensitivity, and they have their worst visual function. And they're constantly fluctuating between their best and their worst visual function, depending upon internal things such as attention, emotion, medication, sedation, illness, and external factors such as motion, contrast, color, and position in space. So patients with nystagmus have a dynamic visual system, much like hormones or blood sugar or blood pressure. Excuse me, I'll wait till it's done. So the way to understand eye movement abnormalities, including nystagmus, is the use of eye movement recording, which is now available cheaply and easily, and anybody can use this. The software is not any more difficult than any software that's used routinely on most of our computers. The problem with using eye movement recordings is not access to it, the cost of it. It's really the interpretation of it, which takes some time and understanding and probably some one-on-one teaching. But the use of eye movement recording has allowed detailed classification, explanations of the neuropathology, as well as a way to follow interventions, all types of treatment. It would be not having eye movement recordings or using eye movement recordings is the equivalent of not being able to understand, diagnose, and treat heart arrhythmias. We don't treat heart arrhythmias by using our fingers and putting them on the pulse. We treat heart arrhythmias by doing electrocardiography. So abnormal rhythms of the eyes are best understood using technical expertise, not the human eye. The human eye cannot understand the oscillation. It has the waveforms. The slow phase of nystagmus has multiple ways of presenting itself. The two most common and easiest are a pure pendulum up to your left and a pure linear slow phase up to the right. These simple slow phases are mostly seen in acquired forms or neurologically significant forms of nystagmus associated with vestibular disease, toxicity, central nervous system tumors, etc. The more complicated forms, waveforms, are seen in infantile nystagmus and only infantile nystagmus, and using eye movement recordings.
Here today, outside at KJP Pavilion from 11 a.m. to 1:30 p.m.
So using eye movement recordings, a slow phase has an increasing velocity exponential and is diagnostic of infantile nystagmus syndrome. Any patient with infantile nystagmus needs to have complete afferent system testing. This includes all of the things you see here. Up to 85 to 90%, depending upon which study is done, of patients who have infantile nystagmus have something else wrong with the afferent system: cornea, anterior segment, optic nerve, retina, or optic or visual pathways. In order to detect these, all of these additional techniques are required, and all the patients that I see have a complete afferent and efferent workup when they're first seen. Treatment of the visual system in patients with nystagmus is best done if you can treat it while it's developing between 1 and 4 months. Unfortunately, this is impossible in most situations, although an investigational paradigm we used with these dogs who had RPE65 deficient retinal disease and infantile nystagmus were treated with adeno-associated virus RPE therapy subretinally, and their nystagmus went away because their retinas were treated and their vision was restored in the weaning period, which would be equivalent to the 1 to 6 month period in humans. So if we can treat it while it's developing, we can cure it. But until then, we can treat the sensory system, the motor system, and treat the patient's symptoms. Non-surgical treatments include everything you see here, including medications. Contact lenses provide 4 advantages in patients with nystagmus. One is the quality of the world and vision is improved. The second is that you can reduce photophobia and light sensitivity with tinting, especially in the patient population with albinism. The third is that if the patients have to use their head to see, they're not looking through the edge of the frame or through the outside of the optical center of the lens. And the fourth is the physical contact of the contact lens with the cornea further reduces the nystagmus. So the use of contact lenses is probably one of the most common things that I suggest in the patient population with INS. Medications can be used to treat both neurologically significant nystagmus and infantile nystagmus. The most common thing that I use is baclofen in patients with periodicity. About 17 to 33% of patients with infantile nystagmus will have a spontaneously changing intensity or direction of their oscillation, and this can be smoothed out with baclofen. This is a very powerful, safe drug used in children for decades. As a result of thousands of surgical procedures on patients with nystagmus, I've come up with this 9-operation algorithm, which can be used clinically and applied clinically, even without the use of sophisticated testing, so that all of us around the world who see patients with nystagmus have the opportunity to improve their vision and visual function by combining 3 simple things, even without a sophisticated workup: eye muscle surgery, contact lenses, and baclofen. If you give this patient population any or all of those combinations, it will improve their vision and visual system. These are the things we've studied as a result of just of eye muscle surgery before and after, and you can see all of these things that are listed here have improved. We did not study 10, 11, 12, and 13, have no plans to at the present time, although the visual functions you see listed above did improve. And these improve after surgery regardless of the type of surgery that was done, whether it was for strabismus, for an anomalous head posture, for strabismus plus anomalous head posture, or no indication other than the nystagmus where the muscles are reattached at the original insertions. All of these visual functions improve. And we don't know why, but we think that proprioceptive afferent interruption or deafferentation of newly discovered enthesial endings at the junction of the extraocular muscle tendon and globe are disrupted during surgery, and these produce the decrease in the nystagmus. So this is a friend of mine, Samir, who leaves me with these sayings as a result of the new discoveries, which I often will turn to as I travel around the world and discuss nystagmus. And you see Ginger here in the background, who is one of our experimental animals, with her brother Stanley at my house here at home, who's doing very well after spending a year with us studying topical eye drops for nystagmus, and she has done well with that. So I think that's a short way of showing you some of the controversies. And I'm happy to field a couple of questions.
Thank you so much, sir. I'm sure we have a lot of questions. Over to the moderators.
Well, thank you, sir. So at the outset, a wonderful overview of nystagmus, and we look forward to having an interesting discussion. I would like to have Professor Pradeep Sharma. He's with us here. Any comments from sir before we take up some questions?
It's always a pleasure to listen to Rich. It's always a rich talk, as it is. And on nystagmus, I think nobody better than him. We have
Yes.
learned so much from him on each of his presentations. Just a little question about what about that miracle drug that you were working on for the cases without any eccentric null? Any thing which has come up that we can use, make use of?
Not quite yet. The clinical trial is going to begin this year in Manila in the Philippines.
Okay.
So the
So
topical drop we're working on it. Yeah, it's finally got it through the FDA, and we got the drug shown that it has stability testing and it's safe, and so we're ready to start the human trials the end of this year.
Okay. And about any comments about brinzolamide or anything else that you are?
Yeah, sure. Azopt, I give to the older children and adults. I do prescribe Azopt or Trusopt, and about 50% of the patients have a subjective, in addition to the objective reduction in the nystagmus, subjectively feel it helps. So about half the patients that I prescribe it for really choose to stay on it because it makes a difference.
Okay.
It's
That's
a nice little addition to surgery. Yeah.
Mhm. Thank you so much. Yeah.
Thank you, Pradeep. It's good to see you.
Yeah. How long have you been giving AZOPs? Like, do you have a long follow-up? What's the
Yeah,
safety?
we did the clinical trial and published it in the British Journal of Ophthalmology in 2018. So I've been using it for quite some years.
Okay. So I have one question. And so for children who use the convergence and the adduction, what would you recommend? What procedure would you recommend for them?
Yeah, so if you have someone who has convergence damping and no anomalous head posture or strabismus, I do a bilateral medial rectus recession of 3.0 millimeters and a bilateral lateral rectus tenotomy with reattachment. You can actually calibrate the bimedial recession by doing a fast prism adaptation in the office. So you can put them in 12 or 15 or 20 base out, sit them in the office for 10 or 15 minutes and see how they adapt, see what their nystagmus is like, and check their acuity under binocular conditions. Because if they can adapt to more, or they can adapt to more or less, then you can actually do the BMR for what you've prism adapted them for. Does that make sense?
Yes. That's quite interesting to note, actually. Also, I would like to know how you deal with the complex head postures. Do you do them and stage them and see how they respond, or do you go for it in all in one?
No, I don't stage the surgery. Even having said that, about 20% of the time I have to do another procedure for an unexpected eye position or a new head position. But 80% of the time, I just go after all of it at once. And there's ways that you can combine the obliques and the vertical and horizontal recti to take care of any head posture. And it's listed in that algorithm.
Yes.
So that helps. And if you do that operation, 80% of the time, you'll take care of them.
Right. That's great. Dr. Shelja, would you like to add some comments? Dr. Shubhojit is also here.
Just a curious question. Sir, you see nystagmus and you treat them all over the globe. You see them in India, you see them in Southeast Asia, and you see them in the US. Is there any difference in how they respond to treatments in different places?
That's a really good question. No, it's funny you bring that up because I was looking for that. So I see a large albino population in China too. And what I've noticed is we are all the same. Humans are the same. We like to eat, we like to sleep, we need to find someone to love, we need to find something to do, and our eye muscles are all the same. They're the same. We're only different on the outside and different with our accents, I think, but I think we're the same.
That's nice.
That's great.
All right.
So, yeah. And may I know how you give the baclofen, and what's the protocol that you follow?
So I'll use, depending upon the body weight, 5, 10, 15, or 20 milligrams 3 times a day. And I ask the patients to use it for 2 weeks and report on how their visual functions have changed in their academic, athletic, and social environments. Okay. And if they and the people around them notice a difference, then they stay on the baclofen. That's also a very safe medication.
Right. And there's a lot of subjective improvement with the baclofen that we do see.
Especially the periodicity, especially in the patients whose head go back and forth and back and forth like that. Yeah.
That's great. Yes. Yeah. So any other comments or questions?
Thank you so much, sir. I think it's like a master class, and we need
Yeah.
more of these from you.
It's a pleasure. I always miss India. I love coming to India, and it's really I love being able to talk and interact with all of you. So I'm happy you made my day today.
Yeah, thank you, Dr.
Thank
Hartan.
you so
It was a quick revision of the class in Rajamundry this year.
Hey, how are you? Yes, nice to see
I'm
you.
good.
Great.
Great.
Okay.
Thank you so
Okay.
much.
Okay, have a great evening.
you
Thank
too.
you.
Yes, you too.
Okay.
Thank you so much.
Bye-bye.
Bye.
So I think before we close the session, we have one last talk by Dr. Kekunia. Ketki, if you want to introduce this topic, then it's a pre-recorded talk. So he has rescheduled his flight, and that's why he missed us. So I'm going to play his talk whenever you guys allow. Should I go ahead?
Yeah, of course. Should I? I mean, we've kind of split that. So I introduced Dr. Keknia.
I think
We can skip that.
yeah, I think so. Fine.
Okay, fine. Yeah.
All right. Let me see.
I do not have any financial disclosure related to this presentation, even though I have this disclosure to make. Today's objective is to learn about 4 challenging situations. Number 1, precision pulse capsulotomy instead of manual capsulotomy in pediatric cataract surgery. Instead of lens in the bag, how about bag in the lens? The third thing I would like to cover is IOL implantation, tips to success in infantile cataract, and possibility of selected cases of microspherophakia where we can implant intraocular lens.
No.
Is it part of the recording, Dr. Aditya?
First one to talk about is the
Right? Yeah.
Okay, okay.
I think this is a locked PPT. If I'm not wrong.
Okay.
So it's a little more difficult to get.
first one to talk about is the precision pulse capsulotomy.
All right, I think but we can just discuss about the topics that he pointed out. I think we're having trouble with his presentation. So these are the topics that Sir has brought up. I think with Zepto, let me just start with that. I think Zepto has not really been tried too much in pediatric cataracts yet. I don't know what Sir had to add to that. They were going to make a new ring just for pediatric.
First one to talk about is the precision pulse capsulotomy. World over, the manual capsulotomy is preferred, but it is tricky. Learning curve is really long. One of the things the Zepto has developed is a precision pulse capsulotomy. This is surgery where it involves the capsulotomy is automated, so that the most common complication of runaway rhexis or difficulties of ophthalmologist in handling pediatric cataract surgery can be reduced if you go to this automated process of intraocular lens implantation preceded by anterior capsulotomy. So this is the nitinol ring with the handpiece there. It takes around 30 seconds to create this opening in the anterior capsule. The capsulotomy done by precision pulse capsulotomy is quite precise, as you can see in this slide here. the video shows the capsule is regular and size and all that, and the margins are quite good. So this is the long-term follow-up of this patient. I would
All right. I'm going to stop sharing. Great. So any comments on Zepto as an option?
So I have had experience, Aditya, with the Zepto. And so I've probably done about 2 cases before I decided, okay, that manual works for me just as fine as. So the thing with Zepto is that we may have to squeeze it through the incision, and we know the pediatric incisions are a little tricky to get in. That's the first thing. And second is the crowded anterior chamber, because we're looking at small eyes and we're looking at this bulky thing going in. So that was the second challenge that I faced personally, to kind of go in and expand it. And you're a little worried that you don't want to touch the endothelium or the iris. Of course, the capsulorhexis itself, capsulotomy itself was really good. The first case, I did have some frayed edges, maybe because of a little coagulation or something like that, but the second case didn't have that. So pulling out is fairly easy. You just have to pull it out like that, and it kind of folds on itself and it removes. So it is a good procedure, but I do see, maybe because I'm more comfortable with the manual, and we do get very good capsulorhexis anyway because of the elasticity of the capsule. You don't have this tearing off or, these irregular sized ones usually with pediatric cases. So that's my experience. Anybody else?
Did you try it for the posterior capsule, or it won't fit at all?
No, it cannot be done because you need a closed chamber, and going a little down, you don't have control, and you need 2, because once you use one and that's it, you'll need to use a second, the second instrument again for this. So, and that the cost factor obviously is a little, you need to take that into consideration. So,
Dr. Shruti, did you change the size of that rim which is available for Zepto?
Yeah, they have 2 sizes, and I think I took the smaller one, the 5 and the 5.25.
Yeah, because we do Zepto. When we do Zepto, the size of the rhexis is little more than what is expected.
Yes. It does expand as well, once we do it, because of the way that it works, I guess. So it kind of expands a little bit more than that. So I do tend to take the smaller size. What is your experience, Dr. Vartha? Like, would you recommend that as a procedure?
I did it for adults, actually. Never tried in pediatric. But yes, as you said, crowding was a major factor. Even putting that rim inside the anterior chamber was a little difficult for adults for me. So I didn't try in pediatric till now.
Yeah. All the more difficult in pediatric, I feel.
Shailja ma'am, do you try the Zepto?
No, I haven't. I just tried in one case, but the major limitation was the cost. So in Shroff, mostly pediatric cataracts are the ones who have the less socioeconomic, I don't know. I feel there is a decreasing trend in cataracts, pediatric cataracts that I'm seeing over the years, and which is a good thing for the society, I feel. But I don't know. Maybe, the private practitioners are doing all pediatric cataract as well, the adult cataracts probably.
Believe me, we are not.
But I don't know if you guys are also seeing that trend, because the number of cataracts I used to do the moment I entered Shroff 10 years back. Now it is, as your practice grows, you think it will increase, but it has reduced, and squints are the same. But I think it's just the amount of cataract coming down, which is a good thing for the society. Even in the camps that we do tend to get lesser children who are undiagnosed or misdiagnosed or late diagnosed as cataracts. We're getting more younger children, which is again a very good thing. So the cost factor is the most important thing for us, and I tried to learn it and try to do it, but then whenever I used to try to incorporate into the surgical package, it becomes very expensive, and ultimately you end up giving discounts to the patient. So for that reason, I'm not doing it. And most of the cataracts that come to me mostly are either complicated cataract, those with anterior segment problems, traumatic cataracts and all, where really it doesn't help. Those with scar and intercapsular plaques and all, it doesn't help. So I think I keep on learning and practicing my manual surgical skills, and that should be good enough.
Yeah.
I would really like to find some solution to do a PPC. If there is like, Dr. Vaishali was showing that, femto, using the femto for a PPC or using some other machine that she was mentioning. If that is something there, then that really gives you an advantage where you can actually do a good, nice big PPC and perform an optical capture. That would be something that I would really look forward to, which would change my pediatric cataract management.
So the PPC has been studied. Dr. Buran Dick, I think he's done a beautiful job, and he's given a very nice how he's adjusted. What really is the main problem? The getting the femto in the same place as the procedure room.
Yeah, and for us, the SHOF, the LASIK machine is a different hospital itself, so it's not possible only. And so that's a very big challenge. But the portable one, which she was saying, some Cura laser or something she was saying, I would really look forward to it.
Capsule laser.
Capsule laser, okay.
I think we actually have a guest performance by a kid at...
Capsule laser is femto based.
I can hear
Sorry.
Was that
it's my son.
Yeah,
it's too much for him now.
Have a real guest appearance by a
pediatric person, yeah.
We should have a dinner over this discussion.
Yeah. Maybe we could shift to the next topic that he was.
Yes. So he was talking about bag in the lens. I think Dr. Vaishali spoke about optic cataract. And she covered most of the points about bag in the lens. And anybody who's done bag in the lens for their pediatric cataracts?
No, I have no. I have tried optic.
Has it?
Yeah.
Sorry. Is it really commercially available now? I think these Arvind people were trying to make something of their own from the help with Dr. Tassignon, but it's not yet out, I think so.
It's not available at the moment. That's what we understand.
Yeah.
But capturing the lens posteriorly is a good option.
Yeah.
And we have 3 pieces now coming in, including I believe a very nice one from Epsilon, if I'm not wrong, where they're using it for Yamane as well because their haptics are so strong. So that's something to get into. Earlier it was the Zeiss one, but Zeiss was not available in India. So so that's
but the challenge with the optic capture is to get the posterior capsule right. So that that's the trick actually. So if you get the right sized posterior, the bigger one, which is just perfect for that kind of you just push it in and then it goes in and that's perfect. Like by some, it's consistent efforts and practice, maybe we could reach there. But more often than not, I always have my single piece foldable ready with me and the 3-piece just in case, I still want to go for an in the bag placement without the capture.
It sounds exciting, especially if you're going to put toric IOLs for slightly older children who can see, because you don't want it to rotate, you don't want to go back to the OT again, so best is to capture it. So there it makes sense, and you never know how these things will be. Like choosing the right IOL for kids is becoming more and more important now.
Yeah.
So that will become a thing. Let's see. And the other topic this was supposed to talk about is infantile cataract and IOL. When will you implant and when you will not? Any comments?
Extremely tricky area.
It's an ever-going debate, since last 10 years. During my fellowship also, I was listening to this. I don't know when it will end, but yes, definitely what the consensus is that, don't implant in eyes which are not normal. And the size. Yeah. So any eye with any other anterior segment problem, do not implant regardless of the age. And what we follow is 18 millimeters of axial length and 10 millimeters of the corneal diameter. That's it. Apart from that, I would implant.
How about the IOL power calculation in those 6 months, 7 months, where the acceleration of the growth is very fast, and 2 years it changes everything?
Yeah. So you can choose to undercorrect more, like probably do eight diopters or 10 diopters of undercorrection, and hoping that. But if you are not sure if the child will wear glasses, because it'll mean a single vision glass of 13 diopters, right? So you can choose over, just implanting a undercorrected six diopter and eventually giving them some myopia. So again, that is dependent on the surgeon, I think.
Yeah.
I think
what do you do, Aditya? What do you all do?
It's more complicated when it's unilateral, I guess, because
correct.
And I recently had a kid who had a family history of high myopia, -15 in the parents, one of the parents, and thereafter, and with unilateral cataract. So that was a question. What do? Do you overcorrect because you know it's going to become myopic? There's a great
right.
And the other eye was already at a +1, and you knew what. And if I leave it too much difference, then anyway there's a chance of amblyopia. So I think these are just gut calls that you have to take.
I think at this point, the modern concept in unilateral cataracts would be to aim more for emmetropia or a slightly closer to emmetropia correction, something that doesn't cause a dense amblyopia in the child. And then, of course, because of the advancements of refractive surgery, we always.
I was about to say that they could always go ahead and exchange the IOL, do a fake, like extra IOL, the what you call piggyback the IOL, and all these things later on. It's best to have the growing age with a correct with the best chance.
Yeah, Dr.
I
Shubhajit.
have a small question. I had faced it recently. So I had a patient, as in, and suppose a patient of that borderline age group comes to you, like 8 months or something. So is it worth waiting for 2 more months and putting the IOL, or like should we just keep the child aphakic? Like that when the borderline age comes.
You mean when the eye grows and then you can calculate the reliable IOL power?
Yeah, that's no. I was not that much. Like whether to put the IOL or not, like whether to leave the child aphakic or not. Like suppose 8 months baby is there.
Bilateral.
Yeah, unilateral. Suppose unilateral patient only came.
And then I think you take a call. Definitely go ahead and do it. Why would you want to wait? You want to
again another procedure, which is again another after 2 months.
No. Put an IOL. See, above 6 months of age, in fact, not much of a below 6 months still you would think, because these eyes are really small and you don't know how they'll behave. So, but beyond 6 months, if the parameters are good, like 18 millimeter or more and 10 millimeter, unilateral cataracts, again, beware of other abnormalities in the eyes, because bilateral ones are those which will be nice and normal, but unilateral may have PHPV, very microcornea, microphthalmos, things like that. So if those are not there, you can safely go and implant a lens. And I would personally aim for a 4 diopters or less of anisometropia, not more than that. Of course, they will progress. They may develop myopia later, but that will handle later.
Yes, I also believe in the same thing. In fact, I would go for a lower anisometropia, because I know I have to get the patient to start seeing as soon as possible, because the unilateral cataracts 8 months means 8 months there's been dense amblyopia. So I would go for a little more aggressively and reduce, maybe +2 or +3 is what I would aim at maximum.
Oh.
Yeah.
What about customized IOLs? I mean, there are smaller IOLs available. Like, have any of you had any experience with these smaller optic IOLs that they are currently actually available? But personally, I don't have any experience with that.
No experience.
So I had one experience with a small, it's not customized. The iris claw lens is available in 2 sizes. One is a small one and one is a bigger one than a normal one. So I did implant in a 12-year-old who was, the corneal diameters were 8.5. So there I used it. In fact, there in his case, the ACPC was fused. It was like a long-standing membranous cataract. So there anyways, we could not have put it in the bag, putting us in a sulcus. Either you need a PMMA customized IOL, which is available. No foldable is customized available in that size. So I approached both the IO Care company, I think makes the customized PMA, and I approached the iris claw. So the iris claw one responded. So I ended up putting an iris claw in that child. So that I have an experience. He's doing fine so far, 6 to 8 months now. That's
so
it.
These
so
are not
bilaterally. So bilaterally, it was important because his axial length was small. if I do get a case where, you know, the axial length is quite okay, as normally, you know, they do tend to have a myopic shift. So many times the aphakic power is not that much. In that case, I would just leave the child aphakic and rehabilitate with glasses. But if the axial length was like a 22 or 23, so he'll land up, you know, with a 25 or 23 diopters of a power, or maybe 18 diopters of a refractive correction. And he had a very bad nystagmus. So I thought probably put in a lens.
Excellent.
But see, even the iris claw, I don't have a long-term experience, like maximum 2 years of experience now with iris claw. So I don't know how these small eyes, when we implant even a customized iris claw, how they will behave in a long term.
I know these are difficult situations. I think with this eye being small to start with, you have many reasons why things will go wrong. So
yeah.
Great. I think great discussion. It's 9 o'clock. So great. I love pediatric ophthalmology at night. Next time we should.
Yeah,
Pediatric
thank you.
people at home, they're
Aditya.
getting restless. All the pediatric people at home.
Yeah.
They're like,
No, but this is
cranky and
fun. This
restless
is,
now.
Slept, so
yeah.
all right, great.
Yeah, thank you, Aditya.
I think this is-
Thank you,
Bye.
Aditya.
Thank you,
Dr.
Thank you so
Sharma.
much.
Thank
you.
you,
I think
Vardha.
Thank you,
phenomenal
everyone.
Aditya.
Thank you, Vardha.
Thank you.
phenomenal
Thank you,
job at the
Kirti.
whole
Thank you,
thing and
Subhaji.
fantastic program.
Thank you, tech support.
Support. Bye.
Bye.
Thank you.
Bye. Bye. Thanks, Aditya.